യെസ് കറക്റ്റ്, അത് ശരിയാവുന്നുണ്ട്.
ഞാനിപ്പോ ഈ സ്ട്രീമിംഗ് സ്റ്റാർട്ട് ചെയ്തു. എന്നിട്ട് പിന്നെ സാറിന് വേണമെങ്കിൽ ഹോസ്റ്റ് ആക്കി നോക്കാം.
ഓക്കെ. ഇപ്പോഴും പോകുന്നുണ്ടല്ലോ അല്ലേ? യൂട്യൂബിൽ പോകുന്നുണ്ടോ? അത് കമന്റ് ഓഫ് ദി മീറ്റിംഗ് ഇസ് അറ്റ് യൂട്യൂബ് തന്നെയുണ്ട്.
ഞാൻ ഇതിലോട്ട്
അല്ല, വലിയ പ്രസംഗമൊന്നുമില്ല, അപ്പൊ പിന്നെ കുഴപ്പമില്ല, പെട്ടെന്ന് മീറ്റിംഗ് ഇരുന്നോട്ടെ, കുഴപ്പമില്ലാന്ന് തോന്നുന്നു.
അല്ല ഇപ്പൊ കിട്ടും ഇനി.
ഹലോ, ഇപ്പൊ ഞാനാണ് ഹോസ്റ്റ്, പക്ഷെ കുഴപ്പമില്ല.
അല്ല സാറിന് ഹോസ്റ്റ് ആക്കിയില്ല.
ആക്കിയില്ലല്ലേ? ശരി ശരി ശരി.
ഞാനൊന്ന് ഹോസ്റ്റ് ആക്കട്ടെ.
ഹോസ്റ്റ് ആക്കി നോക്കട്ടെ, അങ്ങനെ ഒരു നോക്കട്ടെ.
സാറാണ് ഇപ്പൊ ഹോസ്റ്റ്.
ഇപ്പോഴും യൂട്യൂബ് സ്ട്രീമിംഗ് പോകുന്നുണ്ടോ തന്നെയാ തോന്നുന്നത്. മറ്റേ മാഡം ജോയിൻ ചെയ്തിട്ടുണ്ട്.
സാർ മാഡത്തിനൊന്ന് ഈ ശരി.
ഗുഡ് ഈവനിങ് മാഡം.
ഷെയർ ചെയ്ത് നോക്കട്ടെ?
ഷെയർ ചെയ്ത് നോക്കിക്കോളൂ. ഫൈൻ. ഫുൾ സ്ക്രീൻ ആക്കിയാൽ മാത്രം മതി, വിഷയമൊന്നുമില്ല. ഫൈൻ.
ഓക്കെ. അപ്പൊ ഇപ്പൊ സ്റ്റോപ്പ് ഷെയറിംഗ് കൊടുത്തിട്ട് സമയമാകുമ്പോ ഷെയർ ചെയ്താൽ
മതി.
മൂവ് ചെയ്യുന്നൊന്നും കൂടെ നോക്കട്ടെ.
വീഡിയോസ് ഉണ്ടോ?
വീഡിയോസ്
ഇല്ല.
പ്രൊസീജിയേഴ്സ് ഒന്നും ഇല്ലല്ലോ.
ശരി ചോദിച്ചതേ ഉള്ളൂ. ഓക്കെ മാഡം.
പറഞ്ഞ പോലെ സ്ട്രീമിംഗ് ആവുന്നുണ്ട് കേട്ടോ.
സ്ട്രീമിംഗ്
ആവുന്നുണ്ട്.
എനിക്ക് വൺസ് ചെയ്താൽ അങ്ങനെ ഓക്കെ ആവും. പിന്നെ നമുക്ക് ആക്ച്വലി എഡിറ്റ് ചെയ്താൽ മതി, അത് കുഴപ്പമില്ല.
ഞാൻ എന്റെ പേരിൽ ഒന്ന് കേറാൻ പറ്റുമോ നോക്കട്ടെ. ഇത്
പേര് റീനെയിം ചെയ്താ പോരെ?
ശ്രീജിത്ത് സാർ ഒന്ന് സെഷൻ സ്റ്റാർട്ട് ആവുമ്പോൾ നമ്മുടെ റെക്കോർഡിംഗ് പ്രസ് ചെയ്യണേ. ഞാൻ റെക്കോർഡിംഗ് ഇപ്പൊ ഡിസേബിൾ ചെയ്തിരിക്കാം.
ശരി ഓക്കെ.
സാറിന് ഇപ്പൊ ചെയ്യണമെങ്കിൽ ചെയ്യാം റെക്കോർഡിംഗ് ക്ലൗഡില്.
മോറിൽ പോയിട്ടല്ലേ? ഓക്കെ. തുടങ്ങാൻ റെക്കോർഡ് ചെയ്യാം. ഗുഡ് ഈവനിങ് മാഡം.
ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ് കൽപ്പന മാഡം.
ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ് മാഡം.
ജോൻ ഗുഡ് ഈവനിങ്. ജോൻ ആരുടെ? പാർവതിയുടെ ക്ലാസ്മേറ്റ് ആണെന്നൊക്കെ പറഞ്ഞു.
പാർവതിനെ വിളിച്ചിരുന്നു.
ഞാനൊരു മെസ്സേജ് അയച്ചപ്പോഴാണ് പാർവതി പെട്ടെന്ന് ക്ലാസ്മേറ്റ് ആണ്. പിന്നെ രേഖയുടെ ക്ലാസ്മേറ്റ് ആണ് രേഖ നേരത്തെ പറഞ്ഞു. രേഖ
ഞങ്ങള് സ്കൂളിൽ ഒരുമിച്ചായിരുന്നു മാഡം.
സ്കൂളില്ല? ഏത് സ്കൂള്?
ഹോളി ഏഞ്ചൽസ്.
ഏതിലായിരുന്നു മാഡം സ്കൂൾ?
കുക്കു രേഖയും പുളിയഞ്ചൽ സെൻ.
രേഖ എന്ന് പറയുമ്പോൾ നമ്മുടെ ഗൂഗിൾ മെഡിക്കൽ കോളേജ് അല്ല?
അതെ അതെ അതെ.
ആ ഓക്കെ ഓക്കെ. രേഖ മാമിന്റെ ബാച്ച്മേറ്റ്.
ആ ഞങ്ങൾ MBBS ഒരേ ബാച്ച്.
പോൾസർ ഒക്കെ നിങ്ങൾ ഒരേ ബാച്ച്? ഓ ശരി ശരി ശരി.
96 ബാച്ച് MBBS ആണ്.
96 ബാച്ച്. നൈസ്.
പാർവതി 97 ആണ്. പക്ഷെ ഞങ്ങൾ സ്കൂളിംഗ് എല്ലാം ഒരുമിച്ചാണ്.
ഓക്കെ ഓക്കെ. ഷിമി സംടൈംസ് ജോയിൻ. ചിലപ്പോൾ ജോയിൻ ചെയ്യും പാർവതി, സമയം ഉണ്ടെങ്കിൽ കയറാന്ന് പറഞ്ഞിട്ടുണ്ട്.
റെഗുലർ ആയിട്ട് എല്ലാ വീക്കും നടത്തും അല്ലേ മാഡം?
ഇല്ല, ഓൾട്ടർനേറ്റ് ട്യൂസ്ഡേ, once in 2 weeks. അപ്പൊ നമുക്ക് എന്തെങ്കിലും ആ സമയത്തുള്ള ഇൻ ടോപ്പിക്സ് എടുക്കും അങ്ങനെ.
അപ്പൊ നല്ല പണിയല്ലേ കണ്ടുപിടിച്ച് ആളെ ഒപ്പിക്കുക എന്ന് പറയുന്നത്.
ആരെങ്കിലും ഒക്കെ പിടിക്കും. അല്ല, IAPക്ക് തന്നെ കുറേ ഡേയ്സ് ആൻഡ് വീക്സും സ്റ്റേറ്റ് പ്രസിഡന്റ് ആക്ഷൻ പ്ലാൻ അങ്ങനെയൊക്കെ ഉണ്ട്. അപ്പം നമ്മൾ സാധാരണ പീഡിയാട്രീഷ്യൻസിന്റെ ഗ്രൂപ്പിൽ നിന്നാണ് എടുക്കുന്നത്. അപ്പം ഇന്നാണ് ഒരു ഡിഫറെൻ്റ് ആയിട്ട് ജോയിനെ വിളിച്ചത്. എന്നുവെച്ചാൽ ബിക്കോസ് ഹാൻസൻസ് ഡിസീസ് നമുക്ക് അത്ര ഇപ്പൊ കണ്ടിട്ട് ഒരുപാട് കാലമായി അല്ലേ? നമ്മള് PG ഒക്കെ പഠിക്കുമ്പോൾ ഇഷ്ടം പോലെ കണ്ടിട്ടുണ്ട്. പക്ഷെ നൗ നമ്പേഴ്സ് ആർ വെരി വെരി ലെസ്.
കഴിഞ്ഞ ദിവസം ഒരു 3-4 ഡേയ്സ് മുമ്പ് പോലും ഞങ്ങൾക്ക് ഒരു ന്യൂ 1 വീക്ക് ഒക്കെ മുമ്പേ ഒരു ന്യൂ, അതായത് ഫുൾ ബ്ലോൺ ഹാൻസൻ വിത്ത് ഡിഫോർമിറ്റി ഒക്കെ ആയിട്ട്.
ഓക്കെ. ഡെർമറ്റോളജിസ്റ്റ് എല്ലാരും പറയുന്നുണ്ട് ഇപ്പൊ കേസ് കാണുന്നുണ്ട് എന്നുള്ളത്. പിന്നെ
പക്ഷെ എല്ലാം റെഫേർഡ് ആയിട്ട് വരുന്നതേ കിട്ടുന്നുള്ളൂ. കാരണം ഇപ്പം വെർട്ടിക്കലായിട്ട് ഇത് ചെയ്യുന്നില്ലല്ലോ മാഡം, ആക്റ്റീവ് സർവൈലൻസ് ഇല്ലാത്തത്.
രേഖയെ ഒന്ന് വിളിച്ചു നോക്കാം അല്ലേ?
അതെ അതെ.
പ്രശാന്ത് സർ, ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ് ബെന്നോ.
യെസ് സർ.
മെഡിക്കോണൊക്കെ എവിടം വരെ ആയി?
അത് മാത്രം ചോദിക്കല്ലേ, അതെങ്ങനെ പൊയ്ക്കൊണ്ടിരിക്കുകയാണ്.
തുടങ്ങിയില്ലല്ലോ.
ശരി. ടോപ്പിക് കൊള്ളാം. ലെപ്രസി കുറെ നാളായി, കുറെ അടുത്ത കാലത്തൊക്കെ ഡിസ്കസ് ചെയ്തിട്ടില്ല. ജോൻ
നമുക്ക് ലെപ്രസി ഡേയുടെ ആയിട്ട് പിന്നെ ഗവൺമെന്റ് ഒരു പ്രോഗ്രാം വിളിച്ചിരുന്നത്. അങ്ങനെയാണ് ഡോക്ടർ ജോവനെ ഞാൻ പരിചയപ്പെട്ടത്. അപ്പോഴാണ് നമ്പേഴ്സ് ആർ ഇൻക്രീസിംഗ് എന്നും അവയർനെസ് കൂട്ടണം എന്ന് പറഞ്ഞു. അതുകൊണ്ടാണ് നമ്മൾ ഇപ്രാവശ്യം വെച്ചത്.
അശ്വമേധം പ്രോഗ്രാം അല്ലേ മാഡം? അശ്വമേധം
വന്ന് പിന്നെ അതെല്ലാം കുറഞ്ഞു കഴിഞ്ഞ് എല്ലാവരും കുറച്ച് ലാക്സ് ആയിട്ട് ഇരുന്നപ്പോഴേക്കും നമ്പേഴ്സ് കൂടി വരുന്നു എന്നാണ് അവർ പറയുന്നത്.
കുട്ടികളിലും കൂടുതലാണെന്നാണ് റേഡിയോയിൽ ഇങ്ങനെ കേട്ടായിരുന്നു.
അല്ല, കുട്ടികളിൽ വരുന്നത് കമ്മ്യൂണിറ്റി ട്രാൻസ്മിഷന്റെ ഒരു ലക്ഷണമാണെന്നാണ് പറയുന്നത്. കുട്ടികളിൽ കുറവ് തന്നെയാണ്, പക്ഷേ കുട്ടികളിലും കാണുന്നു. അവർ കോണ്ടാക്ട് ട്രേസിംഗിൽ ദേ ആർ ഗെറ്റിംഗ് ചിൽഡ്രൻ, ദാറ്റ് മീൻസ് ദർ ഇസ് കമ്മ്യൂണിറ്റി ട്രാൻസ്മിഷൻ. അതുകൊണ്ടാണ് നമുക്ക് പീഡിയാട്രീഷ്യൻസിനെയും കൂടെ അവയർനെസ് വരുത്തണം എന്നുള്ളവരുടെ ഒരു
രേഖ ജോയിൻ ചെയ്തു.
ലേറ്റ് ആയിപ്പോയി മാഡം, വന്നേ ഉള്ളൂ.
അല്ല, ലേറ്റ് ഒന്നും ആയില്ല, ടൈം ആയതേ ഉള്ളൂ. ഇനി 5 മിനിറ്റ് കൂടി ഉണ്ട്. ഞാൻ പിന്നെ ഇൻട്രൊഡ്യൂസ് ചെയ്യണമല്ലോ എന്ന് വിചാരിച്ച് രേഖയെ ഒന്ന് ഓർമ്മിപ്പിച്ചതാണ്. രേഖ ഇവരൊക്കെ കുക്കു എന്നാണ് പറയുന്നത്. ആണല്ലേ? എൻ്റെ മോള് കുക്കു ആണ്, കുക്കു എന്നാണ് വിളിക്കുന്നത്.
ജോനും ഞാനും ഹോളി ഏഞ്ചൽസ് തൊട്ടുള്ള പരിചയമാണ്.
അതെ മാഡം, അല്ലെങ്കിൽ മെഡിക്കൽ കോളേജ് മാത്രമായിരുന്നെങ്കിൽ മറ്റേ പേര് അറിയത്തില്ലായിരുന്നു.
അറിയത്തില്ലായിരുന്നു.
ബസ് എല്ലാം ഞങ്ങൾ ഒരുമിച്ചായിരുന്നു. അപ്പൊ
ജോന്റെ വീട് എവിടെയാ?
മാഡം ഇപ്പം പാളയം ജൂബിലി ഹോസ്പിറ്റലിന്റെ തൊട്ടടുത്ത്. നേരത്തെ ചാലക്കുടി റോഡ്. ഡോക്ടർ സാംസന്റെ മോളാ മാഡം.
ഓക്കെ ഓക്കെ, ഓർത്തോ അല്ലേ? ശരി, നമ്മുടെയൊക്കെ സാറാണ്.
ജോന്റെ പേരില്ല, ജോന്റെ പേര് മാറിയിട്ടില്ല.
പേര്
ജോൻ സാംസൺ ഫെലിസിറ്റാന്ന് തന്നെയല്ലേ?
അതെ 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 അതെ.
ആരൊരു കത്തി കാണിച്ചു.
അല്ല, ഞങ്ങൾക്ക് സംശയം ഉണ്ടായിരുന്നു, എന്നാലും ഡെഫിനറ്റ് ആയിട്ട് അറിഞ്ഞുകൂടായിരുന്നു ഇതാണോ എന്ന്. ഞാനും ശ്രീജിത്തൂടെ ഇങ്ങനെ സംസാരിക്കുകയായിരുന്നു, സാംസൺ സാറിന്റെ മോളായിരിക്കുമോ എന്നിങ്ങനെ.
എന്റെ ഹസ്ബൻഡ് ലിബു കമ്മ്യൂണിറ്റി മെഡിസിൻ.
എവിടെ?
ലിബു
ഇപ്പം പാരിപ്പള്ളി.
പാരിപ്പള്ളി ഗവൺമെന്റ്. ഓക്കെ ഓക്കെ.
കമ്മ്യൂണിറ്റി മെഡിസിനിലെ ഡോക്ടർ ലിബു ആണോ?
അതെ അതെ മാഡം.
ഓ, നല്ല പരിചയമാണ്, ഞങ്ങൾക്കൊക്കെ വലിയ ഇഷ്ടമുള്ള ആളാണ്.
ലിബുനെ കൂടുതൽ പരിചയം.
ലിബുനെ വലിയ ഇഷ്ടമാണ്.
ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ്. ഇന്ന് നേരത്തെ കയറി, സാറിന് എപ്പോഴും കേറുമ്പോ ചിലപ്പം കുറച്ച് കഴിയും. അപ്പൊ ഇപ്പൊ കൽപ്പന ഇപ്പൊ മെസ്സേജ് ഇട്ടോണ്ട് ഞാൻ ഓർത്തു അങ്ങ് കയറി.
അല്ല, നമുക്ക് ഇച്ചിരി നേരത്തെ കയറിയ ഇങ്ങനെ അങ്ങോട്ടും ഇങ്ങോട്ടൊക്കെ വർത്താനം പറഞ്ഞോണ്ട്
കാണാൻ പറ്റും. ഇപ്പം ഇത് ഹാൻസൺ ഏതോ ഒരു പേഷ്യന്റിനെ അടുത്ത കാലത്ത് ഞങ്ങളുടെ ഏതോ ഒരു യൂണിറ്റിൽ ഉണ്ടായിരുന്നെന്ന് പറയുന്നത്. ഓൾറെഡി ഡയഗ്നോസ്ഡ്. എനിക്കെന്നാ ഒരു കുട്ടി അത് അങ്ങനെ കേട്ടു. എന്റെ യൂണിറ്റ് അല്ല, വളരെ അപൂർവമാണല്ലോ ഇത്.
പക്ഷെ അഡൾട്ട്സിലെ നല്ലപോലെ നമ്പേഴ്സ് കൂടിയിട്ടുണ്ടെന്നാണ് പറയുന്നത്.
ആണ്, ബിക്കോസ് ഈ ഇതല്ലേ ഭയങ്കര നോർത്ത് ഇന്ത്യയിൽ ഇങ്ങോട്ട് ആൾക്കാർ വരുമല്ലേ, ക്ലോസ് മിംഗ്ലിംഗ് ഒക്കെ വരുമ്പോ വരാൻ സാധ്യതയുള്ള സാധനമാണല്ലോ.
ഗുഡ് ഈവനിങ് മാഡം. ഷീല മാഡം.
ഗുഡ് ഈവനിങ്. ഞാൻ ഒന്ന് ഷെയർ ചെയ്ത് നോക്കോട്ടെ ശ്രീജ്.
ഷീല, ബൈ.
ഒന്ന് ഷെയർ ചെയ്തോട്ടെ.
മാഡത്തിന് പറ്റുന്നില്ലേ മാഡം?
എന്തോ എനിക്ക് ഇതിനകത്ത്
മാഡം ഓപ്പൺ ചെയ്ത് വെച്ചിട്ടാണോ ഷെയർ ചെയ്യുന്നത്?
ഓപ്പൺ ചെയ്തൊക്കെ ഡെസ്ക്ടോപ്പിൽ ഇരിപ്പുണ്ട്. ചിലപ്പോ ഈ ആപ്പിളുമായിട്ട് ചിലപ്പോ ഒരു ഇത് വരുമല്ലോ അല്ലേ?
അല്ല, യൂഷ്വലി കുഴപ്പം വരാറില്ല. ആപ്പിൾ എന്ന് പറഞ്ഞ് കുഴപ്പം വരേണ്ട കാര്യമില്ല മാഡം. അങ്ങനെയാണെങ്കിൽ ഒന്ന് ഇറങ്ങിയിട്ട് രണ്ടാമത് കയറി നോക്കൂ മാഡം. ഒന്ന് ലീവ് ചെയ്തിട്ടെ തിരിച്ച് ജോയിൻ ചെയ്ത് നോക്കും.
ആണോ?
ഗീത മാഡം, നമ്മുടെ ഈ ഹാൻസൻസ് ഇടയ്ക്കിടയ്ക്ക് വരുന്നുണ്ടെന്നാ പറയുന്നത്. ശരിക്കും ഗവൺമെന്റ് തന്നെ ഒരു പ്രോജക്റ്റ് ഉണ്ടായിരുന്നു, അശ്വമേധം എന്ന് പറഞ്ഞു, പീഡിയാട്രിക് ലെപ്രസിക്ക് വേണ്ടി മാത്രമായിട്ട്.
അല്ല, പീഡിയാട്രിക് അല്ല, അത് അഡൽറ്റിന്റെ ആയിട്ടാണ് തുടങ്ങിയത്. ഇപ്പൊ 4.0 എന്തോ ആണ് അത് ഓടുന്നത്. എനിക്ക് ഓർമ്മയുണ്ട്.
ഒന്ന് ഫുൾ സ്ക്രീൻ ആക്കിക്കേ. ചേഞ്ച് ചെയ്ത് നോക്കിയേ, ഒരു സ്ലൈഡ് ഒന്ന് മൂവ് ചെയ്ത് നോക്ക്. ഫൈൻ.
ചേഞ്ച് ചെയ്യുന്നുണ്ടോ?
സ്റ്റോപ്പ് ചെയ്യാം. ഓ ഇന്ന് മൾട്ടിപ്പിൾ പരിപാടികളാണ്. മെഡിക്കോ ലീഗൽ ഡേ, എല്ലാ
മെഡിക്കൽ ലീഗലിൽ ആരെങ്കിലും നോക്കി, പക്ഷെ അവര് ഒരുപാട് പ്രോഗ്രാം.
ഒരു ഡോക്ടറെ
അതെ അതെ അതെ. വേറെ ദിവസം നടത്തിയാൽ മതി മാഡം. ഈ വീക്കിലോ അടുത്ത വീക്കിലോ തുടക്കത്തിലോ
അടുത്തൊരു മീറ്റിംഗിൽ
ഈ മാസം
നമുക്ക്
എപ്പോഴെങ്കിലും
മൂലയിൽ
ഒന്ന്.
സാറിനെയോ ആരെങ്കിലും വിളിക്കാം.
ആ മതി. അതെ അതെ. അല്ല ഞാൻ വിചാരിച്ച നമ്മളീ മെഡിക്കൽ ലീഗൽ എന്ന് പറഞ്ഞിട്ട് നമുക്ക് രണ്ട് രീതിയിൽ ചെയ്യാം. ഒന്ന് ഡോക്ടേഴ്സിന്
നമുക്ക്
വേണ്ടിയിട്ട്
ഡോക്ടേഴ്സിന്
സെഷൻ വെക്കാം.
വേണ്ടിയുള്ള ഒന്ന്
ഏതെങ്കിലും
വെക്കുന്നതല്ലേ
ഈ പറഞ്ഞ
നല്ലത്.
പോലെ
പോക്സോ
പ്രശ്നം
വേണമെങ്കിൽ
വന്നാൽ.
ഒക്കെ വെക്കാം, അല്ലെങ്കിൽ
അതെ 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 അതെ. അല്ല മാഡം പറഞ്ഞത് ശരി. കാരണം ഇത് ഈ ദിവസം ശരിക്കും ഡോക്ടേഴ്സിന് വേണ്ടിയിട്ടുള്ളതാണ്. അപ്പം
ആണ്.
ഡോക്ടേഴ്സിന് വേണ്ടി വെക്കുന്നതാണ് എൻ്റെ ശരി.
ആരെങ്കിലും ഉണ്ടെങ്കിൽ ഒന്ന് റിയാസ് പറയുന്നു.
ചോദിക്കാം മാഡം.
ശരി.
കൽപ്പന അല്ല, ഞാൻ എൻ്റെ ഒരു ഫ്രണ്ട് ഉണ്ട്, അറിയാമെന്ന് അറിയില്ല, ഡോക്ടർ ഷീലയ്ക്കൊക്കെ അറിയാം. ഡോക്ടർ റീന ഒഫ്താൽമോളജിയിലാണ് പുള്ളി. ആക്ച്വലി ബാംഗ്ലൂരെ ഒരു ലോ സ്കൂളിൽ നിന്ന് ഇതിന്റെ ഡിഗ്രി ഒക്കെ എടുത്തു ഇപ്പം. അപ്പം
ആര്
പുള്ളിക്കാരി
ആര്
അഫ്താൽ,
റീന,
റീന.
നമ്മുടെ റീന
റീന ഇതില് എന്തില് ഡിഗ്രി എടുത്തു?
ലോ, ഈ ഇങ്ങനത്തെ മെഡിക്കൽ ലോ ഇല് ഇപ്പൊ ഒരു
ലിറ്റിഗേഷൻ
ആണോ
അല്ലേ?
റീസെന്റ്.
ആണോ
ആ
അത് ശരി,
ഉം.
അതെനിക്ക്
അപ്പൊ
അറിഞ്ഞൂടാ.
പുള്ളിക്ക് വലിയ ഏതോ ഒരു, എനിക്കൊന്ന് ചീഫ് ജസ്റ്റിസ് ഒക്കെ ഒപ്പിട്ട സർട്ടിഫിക്കറ്റാ.
അയ്യോ
അങ്ങനെ കുറെ
എനിക്ക് അറിഞ്ഞൂടാ
അല്ല,
കഷ്ടപ്പെട്ടു.
കേട്ടോ.
എങ്കിൽ
റീന അത്
നമുക്ക്
പഠിച്ചത്
വെക്കാം.
അറിഞ്ഞൂടാ,
എങ്കിൽ
അത്
നമുക്ക്
അറിഞ്ഞൂടാ.
അപ്പൊ
ട്രൈ
ഞാൻ
ചെയ്യാം.
ചോദിച്ചു. അപ്പൊ ഞാൻ
കൈതമുക്കിൽ എന്റെ
ചോദിച്ചേ
അപ്പുറത്തെ വീട്ടിലെ കൈതമുക്കിൽ എന്റെ അപ്പുറത്തെ വീട്ടിലുള്ള കുട്ടിയാണ്. നമ്മുടെ 3
അത്
വർഷം
തന്നെ
സീനിയറാണ്.
എനിക്കറിയാം, എനിക്ക് നന്നായിട്ട് അറിയാം.
അറിയാമോ
അതെ.
അറിയാമോ?
എന്തോ
ആ
രീതിയിൽ ഞാനും
ആ
മിനിയും കൂടെ ഏതോ മീറ്റിങ്ങിന് പോയപ്പം പരിചയപ്പെട്ടു.
ആ
അതെ അതെ.
അത്
അപ്പം
ശരി അത്
പുള്ളി
ശരി.
ഭയങ്കര. അപ്പൊ ഞാനിങ്ങനെ ചോദിച്ചു. അപ്പൊ പുള്ളിക്കാരിക്ക് എന്തൊക്കെയോ അവരുടെ എന്തോ മീറ്റിംഗ് ഒക്കെയാണ്. അപ്പൊ എന്നോട് ചോദിച്ചു മാർച്ച് ഫസ്റ്റ് വീക്ക് കഴിഞ്ഞിട്ടാണെങ്കിൽ റെഡി എന്ന്
അല്ല,
പറഞ്ഞു.
ഈ മാർച്ച് 4-ന് പറ്റുമോന്ന് ഗീത ഒന്ന് ചോദിക്കുമോ?
ഞാൻ
എങ്കിൽ എന്നാ
ചോദിക്കാം.
അറിയിച്ചാൽ നമുക്ക്
പക്ഷെ
4-ന് വെക്കാം.
ഞാൻ അയാളോട് ചോദിച്ചു. അപ്പൊ അയാൾക്ക് ഒത്തിരി നന്നായി ചെയ്യണം. അപ്പൊ എന്റെ അടുത്ത് പറഞ്ഞു, ചുമ്മാ പറഞ്ഞിട്ട് കാര്യമില്ല, നിങ്ങളൊരു 3 4 2 3 സെനേറിയോ പറയണം. ഇങ്ങനെ നിങ്ങൾക്ക് ഇങ്ങനെ പ്രശ്നം വരുന്ന 1 2 സാങ്കല്പികം പറഞ്ഞാലും മതി. അപ്പം പുള്ളിക്കാരി അതിനനുസരിച്ച് പറയാം. അതായിരിക്കും ആൾക്കാർക്ക് ഇഷ്ടം, ഐ മീൻ ഇൻട്രസ്റ്റിംഗ് എന്നൊക്കെ ഇങ്ങോട്ട് പറഞ്ഞു. അപ്പൊ ഞാൻ പറഞ്ഞു ഞാൻ ചോദിച്ചിട്ട് പറയാംന്ന് പറഞ്ഞ്. എല്ലാം 17 പറ്റൂലല്ലോ എന്ന് വെച്ച് പിന്നെ പറയാത്ത അതുകൊണ്ടാണ്.
അപ്പൊ നമുക്ക്
അങ്ങനെ പറയണെങ്കിൽ
4-ന്റെ ഒന്ന് ചോദിക്കും, ഇന്ന് തന്നെ ചോദിക്ക്.
ഞാൻ ചോദിക്കാം. 4 അയാൾ എൻ്റെ അടുത്ത് ഫസ്റ്റ് വീക്ക് കഴിഞ്ഞിട്ടെന്നാണ് പറഞ്ഞത്.
അല്ല
അതാണ്
സാരമില്ല,
ഒരു പ്രശ്നം.
4 ചോദിക്കും. ഫസ്റ്റ്
ഗീതയുടെ
സെക്കൻഡ് സൺഡേ ആണ്, അപ്പൊ
ക്ലാസ്മേറ്റ് ആണ്
സെക്കൻഡ്
അല്ലെ?
വീക്ക് ആണ്.
അതെ അതെ.
ഗീതയുടെ
എൻ്റെ
ക്ലാസ്മേറ്റ്.
ക്ലാസ്മേറ്റ്. അതാണ്.
ഉഹും.
അപ്പൊ എന്താ മാർച്ച് 4-ാം തീയതി എന്താ പരിപാടി? നമ്മുടെ
ഇതേപോലെ വെബിനാർ,
ഓൺലൈൻ.
ട്യൂസ്ഡേ
പക്ഷെ
വെബിനാർ.
പ്രശ്നം അയാൾ പറഞ്ഞത് നമ്മൾ ആരെങ്കിലും ഇങ്ങനെ സെനേറിയോ ചോദിക്കണം, അപ്പൊ അയാൾ ആൻസർ ചെയ്യും. അങ്ങനെയാണ് അയാൾ പറഞ്ഞത്.
അതല്ലെങ്കിൽ നമുക്ക് മന്ത്ലി മീറ്റിംഗിൽ വെക്കാം, മാർച്ച് 14th.
അങ്ങനെ ചോദിക്കാം. അപ്പൊ ഞാനൊന്ന് ചോദിച്ചിട്ട് പറയാവേ.
മന്ത്ലി മീറ്റിംഗ് വെക്കാം.
ഓക്കെ
റീന
ഓക്കെ.
ആണെങ്കിലേ
പറയണം. ഉണ്ട്.
അത് വരും. അയാൾ ഇവിടെ പാട്ടത്തോട്ട് വന്നു. അപ്പൊ ഇതാണ് പ്രശ്നം. നമ്മളൊരു 2 3 സെനേറിയോ
അതൊക്കെ നമുക്ക് കൊടുക്കാം, അത്
അല്ലെങ്കിൽ
സാരമില്ല.
സ്മാർട്ട് ആയിട്ടുള്ള പിള്ളേർ വേണം അത് ചോദിക്കാനും ഒക്കെ. മനസ്സിലായില്ലേ? അപ്പോഴേ അതിനൊരു
ക്വസ്റ്റ്യൻസ് ഒക്കെ
ഇതുള്ളൂ.
ആദ്യം സിനാരിയോ പ്ലാൻ ചെയ്ത് വെക്കണം,
പ്ലാൻ
എന്നിട്ട്
ചെയ്യണം.
ചോദിക്കണം.
അയാൾ പറഞ്ഞു അങ്ങനെ ചെയ്താലേ നന്നാവുള്ളൂ.
എന്നാ
അയാളിപ്പോ ആർക്കോ
14th
ചെയ്തു എന്ന്
ചോദിക്കേ
പറഞ്ഞു.
ഗീത, 14th
എന്തോ അതെ
ചോദിക്കേ. ഇഫ് ഷീ ഈസ് ഫ്രീ നമുക്ക് ബാക്കിയുള്ളത് നമുക്ക് പിന്നെ ശരിയാക്കാം.
ഓക്കെ, ഞാൻ പറയാം. ശരി. ഓക്കെ
ഓക്കെ, താങ്ക് യു ഗീത. അപ്പൊ നമുക്ക് തുടങ്ങാം അല്ലേ? 7:33 ആയി.
തുടങ്ങാം മാഡം.
തുടങ്ങാം. So welcome all to the IAP Thiruvananthapuram platform of Tuesday Academic Series. And today we have 2 important speakers and for lined up today for important talks on Hansen disease as well as skeletal dysplasia. And I welcome Dr. Kalpana Madam to say a few words to address the crowd. Kalpana Madam.
Dear Riyas, Dr. Sheila, Dr. Rekha, Dr. Joan, Dr. Geeta, Dr. Srijit, and so many members have joined even before also, because the topics are interesting. And these topics we have selected mainly because last January 30th is the leprosy day. And in connection with that, government has organized a high-level meeting, and IAP Thiruvananthapuram was actually a part of that, and they have invited us also. And so they have told that there are actually 450 cases like that. So many cases of Hansen's is coming, not in children but in adults, and there are cases in children when they are searching for the contacts. So cases are coming, and now the new generation of pediatricians might not have seen cases. That's what I felt. So I thought we'll invite a dermatologist, and Dr. Joan is actually the secretary of the Trivandrum IADVL. So then the second session is by our own Sheila on this skeletal dysplasias. That is also a very interesting topic, and we will discuss that after Joan's talk. And now I invite Riaz for saying a few words.
Thank you, madam. So again, one more session of IAP Trivandrum's well celebrated Tuesday series. So actually, the attendance is also. I could see many of our teachers also, and the speakers today are special because one is a very much celebrated senior, Sheila madam, and an equally distinguished junior, Dr. Joan. So both of them are dear to me also. So I'm eager to listen to both of you. I'm not taking much of your time. I may not be able to listen fully, but I know there will be a YouTube link which I can hear later. So best wishes for the teaching session. All the best. Thank you.
Thank you, Riaz. Now I invite our dear Rekha, who is the classmate of Dr. Joan, to introduce the speaker.
Thank you, madam. Thank you, madam. Thank you for the opportunity for inviting Joanne, yet another one gem from our 96 batch from Trivandrum Medical College. So quite proud to be here. She's the HOD, professor and HOD of dermatology in Karakoram Medical College, and a very good dermatologist. So the topic very carefully chosen. Yes, as sir said, many of us have not seen cases of Hansen. So I was also thinking why this topic was chosen. So it is actually an eye-opener for us that the cases are upcoming. And even when discussing with Joanne was telling there are several aspects through it to this topic, which as pediatricians we are supposed to know. So over to you, Joanne. Looking forward to an interesting session.
Welcome Ananda madam also to the session. She has joined. Okay, we can start the program.
Good evening. I am actually extremely happy to be part of this august team. First, let me thank Kalpana madam for giving me this opportunity to present this topic, and all the IAP team of Trivandrum. Good evening all. I'm sure when you first saw this topic, all of you would have thought, why this old gen disease in this new generation? Yes, but we need to know something about Hansen's disease, and madam has carefully tailored the topic also. Okay. It's not moving.
Movie innilla? Okay. Now it is
as dermatologists, we often face this question: is leprosy still prevalent? And the answer to it is a big yes. Yes, leprosy. And we dermatologists love to call it Hansen's disease and not leprosy, because all of you know that leprosy is one name which has so much stigma associated with it. So Hansen's disease is a better fashionable disease to call our age-old leprosy. It is a chronic disease, as most of us know, caused by Mycobacterium leprae, and the transmission is by droplets which carries the bacteria from the nose or mouth of an untreated case of multibacillary leprosy. To the question, is leprosy still there? Yes. India declared leprosy eliminated at national level in 2005, but the word elimination in leprosy means when the case goes below 1 per 10,000 population. So elimination, it is not eradication, it is just elimination. Okay, less than 1 case per 10,000 population. And maybe to your surprise, India still accounts for more than half of the world's new leprosy patients. So coming to the statistics in Kerala, though we are having a prevalence rate is very less. It is less than 0.1. It is actually 0.11%. But you can see that the number of cases is remaining almost the same. This is only up to December 2024-25 statistics, only up to December. In prevalence of leprosy is calculated from April to March the next year. So cases will get added up in this 261. Okay, but of interest to you would be the number of child cases. It is 90 in 261, which means that 7.3%. So from 2022-23 to 23-24-25, we can see that the number is actually has increased. So it is very important that all of us have a basic idea of Hansen's disease. Hansen's disease is a chronic infectious disease which is caused by, as I said earlier, by Mycobacterium leprae, which primarily affects the peripheral nerves. But it can affect skin, muscles, eyes, bones, testes, and even most of the internal organs when the bacterial load increases beyond a level. Now coming to the cardinal signs of leprosy. As all of us are aware, all of us know, it is a hypopigmented, that is a whitish or an erythematous reddish skin lesion with loss of sensation, or a thickened peripheral nerve, or demonstration of acid-fast bacilli in the slit skin smear. But once we go through my presentation, you will understand that diagnosing Hansen's is not that easy because it presents with varied clinical features. These are the three cardinal signs of Hansen's disease. When talking about Hansen's disease, we should never forget this great personality. Yes, Gerald Armour Hansen, who first saw the agent Mycobacterium leprae under the microscope, thus changing the whole outlook of Hansen's disease or leprosy, which was once considered to be, what do you say, God's curse or genetic disease, was renamed to a disease which is treatable with antibiotics because the organism was a bacteria called Mycobacterium leprae. And a bit about the organism, it is an obligate intracellular parasite, and the optimum temperature for its growth is 30 to 33 degrees centigrade, which is a bit lower than the human body core temperature. That explains why Hansen's disease or the M. leprae prefer the peripheral cooler body parts. Incubation period is long, 2 to 5 years, but cases with incubation period less than 3 months up to 30 years have been reported in literature. So it is a wide range of incubation period. And as I said earlier, the mode of spread is basically inhalational, though direct contact and through ingestion has also been recorded. Ingestion is basically through an untreated mother's breast milk. If Hansen was a hypopigmented lesion with loss of sensation, that is anesthesia, or a thickened peripheral nerve, things would have been very easy, but not. Why? Because it presents with diverse clinical presentations. When it is diverse, it leads to delayed diagnosis or misdiagnosis. Adding on to the burden will be an unresponsive to conventional modes of treatment. And since the treatment period is long, there is a non-compliance part from the patient along with this. As I said earlier, Hansen's disease is not a single lesion or a single nerve which clinches the diagnosis. It is a spectral disease. What do you mean by spectral? It has a lot of clinical manifestations coming under different names. And the person to classify Hansen disease meaningfully were Ridley and Joplin. And that name and the classification is called Ridley and Joplin classification. And the most important thing to be noted in this classification is basically it's an immunological classification. What do I mean by immunological classification? Because Hansen's disease, that is the lepra bacilli, was and is going to be the same with same infective capacity in whichever human it affects. But the difference in the clinical manifestation occurs because of an individual's specific immune response to M. leprae. It is quite individual specific. So We'll come to it. It will be more clear. So classification by Ridley-Joplin is basically into 5 types. When a person has a very good immunity, he or she falls into the tuberculoid spectrum, followed by when the immunity is a bit less, it comes to borderline tuberculoid, bit more less, mid-borderline, then borderline lepromatous, and a person with very less immunity to M. leprae develops lepromatous leprosy. In India, but we have all these 5 classifications. Along with it, Indian Leprology Association has put forward two more types of Hansen's disease. And I'm sure to you pediatricians, indeterminate leprosy will be more important because many pediatric children present with this type of leprosy. And then another variant is polyneuritic leprosy. All these are very early features of Hansen's disease. In polyneuritic leprosy, the skin lesions are yet to develop. If you are able to pick it up very early, then the prognosis is going to be very good. Now coming to the different types, 1 or 2 slides about each type of leprosy in the spectrum which comes under Hansen's disease. First is tuberculoid leprosy. When the person has a very good immunity. Of course, if he has very good immunity, he will never develop Hansen's disease. But if his immunity is very better, then the person's resistance or his body's immune reaction against the M. leprae bacilli is going to be very high, so that the disease is well contained within his body, leading on to the development of, as shown below, well-defined lesions, well-defined skin lesions. And since every organ to that area is destroyed by the inflammatory cells, it is going to be dry because sweat and sebaceous glands are lost. It is going to be anesthetic because the peripheral nerve twigs, which are innervating that area, it has been lost, and there will be loss of hair. Okay, but if the immunity is 1 step lower, that is borderline leprosy. Now borderline tuberculoid leprosy, correct? Borderline tuberculoid leprosy, you can see the well definition is lost at certain sites. If you can follow the cursor closely, it is lost at some sites. So the lesions are partly well defined and partly ill defined, and you can get something called a satellite lesion. See the variation in the clinical features. Now coming to the next step, that is borderline leprosy. That is the type of leprosy which is quite unstable in its immunity and also presents with a lot of varied manifestation, posing a challenge even to dermatologists to make a definite diagnosis of Hansen's disease, because the number of lesions will be high because the immunity is less. Then the lesion can have polymorphic geographic appearance, you can get punched out appearance, and the peripheral nerves also start thickening. Now coming to 1 step less of immunity, that is borderline lepromatous. The lesions are numerous but still countable, and I'm sure you can make out the coppery hue. The hypopigmented erythematous lesion has turned out to be a coppery macules, and the most important cause of a delay in diagnosis or a wrong diagnosis is the minimal sensory loss. Now, from an anesthetic patch, the anesthesia is slowly coming down. The nerve damage to that particular site is slowly coming down. So, minimal sensory loss, which can be missed in many conditions, but there'll be multiple peripheral nerves will be thickened in this condition. Now we're coming to the last of the group, that is lepromatous leprosy, where the bacteremia has become so high that most of the internal organs are involved, that is cutaneous and visceral lesions start appearing. Yes, in the topic we had something like clues to early diagnosis. The first feature of lepromatous leprosy is going to be pedal edema and epistaxis. But all of you will be with me when I say you need a sixth sense to diagnose lepromatous leprosy from a patient who has epistaxis or bilateral pedal edema. So almost always it is missed at this level. Again, as in borderline lepromatous leprosy, the number of the lesions have a coppery hue. They are numerous. They are symmetrically distributed. And the leonine facies, I have it in the next picture. I will show you the typical leonine facies. If that is there, I'm sure all of us are going to diagnose it as Hansen's disease. But we usually don't get those type of lesions in childhood leprosy. And the well-known glove and stocking anesthesia, patchy loss of peripheral sensation. In diabetes and all the other polyneuropathy, you almost always get a diffuse loss of sensation. Here it is, though glove and stocking, there is a patchy loss of sensation. And the earlobe infiltration can be very well appreciated in this picture. Now, this is a typical leonine facial seen in lepromatous leprosy. We can see that the forehead is infiltrated with M. leprae, leading on to the deepening of the furrows. There is a loss of hair, that is both supraciliary and ciliary madarosis is seen, flattening of nose, and this earlobe cannot be appreciated in this picture. So these are the different types of leprosy according to Ridley-Joplin classification. And as I said earlier, Indian Association of Leprologists have 2 more because of the active surveillance which was going on in our country up to 2005. We had picked a lot of early cases. And I said indeterminate leprosy. The term is very self-explanatory. Something is yet to be determined. What is to be determined? Because it's almost always occurs in a child, and here the immunity of that child to M. leprae is yet to be determined. So most of the time it presents as a solitary, as seen in this picture, hypopigmented and a vague macule on the face. Face is the common site for this, and as all of us know, multiple nerves supply the facial skin. So to appreciate anesthesia is not that easy in a facial lesion. Sensory loss is difficult, as I said, it's difficult to appreciate. And we need not be in, we need not be more tensed about the situation, because more than 70% of the cases can resolve normally without any treatment. The rest might go into any of the types which I said earlier. If the immunity is high, these lesions can develop a peripheral thickening going on to tuberculoid type, or if the immunity of the child is less, multiple similar looking lesions can occur, that is, the child is going into lepromatous type. Yes, these are the close differentials which we have when we see a case of indeterminate leprosy. I'm sure all of you in today's OP would have seen at least 1 or 2 of these lesions. Like this is the age-old pityriasis alba, which is just a dry eczema on the face. It's a very close mimicker of indeterminate leprosy. But here you can see a mild scale. And this is pityriasis versicolor, Atynia versicolor. This is an early vitiligo. And this is nevus anemicus. So these are the close differentials when in a case of indeterminate leprosy. And as I said earlier, polyneurotic or pure neurotic leprosy is another variant, the nerve is well seen here, in Indian classification. The diagnosis, to make a definite diagnosis, maybe you need to demonstrate AFB in slit skin smear, but that is not always necessary. And coming to the histopathology, as I said, like the clinical features which have a varied manifestation, even the histopathology shows a varied manifestation in different types of leprosy. But a demonstration of an intraneural granuloma or a presence of acid-fast bacilli by White-Ferraco is very diagnostic. These are the 2 ends of the spectrum. This is the tuberculoid Hansen histopathology, and this is the lepromatous type histopathology. You can very well appreciate the granuloma eroding into the epidermis in case of tuberculoid leprosy, and in lepromatous leprosy where the immunity is very low, we can see that the granuloma is below, much below in the dermis, with an area of normal dermis in between, that is cell-free zone, which is called a Gren zone. So just like the clinical features, the histopathology has also a varied manifestation. Now coming to the treatment aspect, when Hansen found out M. leprae under the microscope, it was a boon to everyone. It was a miracle. It was a life-saving thing. And then Dapsone was found to be effective against Mycobacterium leprae, and everyone was happy and was taking Dapsone, patient was getting better. But since it is a single drug, and since it is a disease which needs a longer duration of treatment, very long duration of treatment, up to 5 years to lifelong treatment, slowly Dapsone resistance started becoming a problem. So WHO study group then came out with something called a multi-drug therapy in 1982, where 2 to 3 drugs are included in the treatment of Hansen's disease. Why multi-drug therapy? When the duration of the treatment comes down, the compliance becomes more. When the compliance becomes more, there'll be less of drug resistance, and also multiple drugs leads to less of drug resistance. And since the treatment duration is less, there'll be less of side effects. Once the patient is more compliant, when there is less of drug resistance, then the chance of relapse is less. Then the treatment becomes more effective. And one important thing of multi-drug therapy is all the 3 drugs are absolutely safe in pregnancy and lactation. That is one important point. And coming to the treatment, WHO has again classified, not like the big spectral disease, they have classified it just into 2 for easy treatment purpose. One is paucibacillary, and the next is multibacillary. As the term suggests, paucibacillary when the leprabacilli is less, and multibacillary when it is more. So WHO has classified paucibacillary into up to 5 skin lesions, and when AFB is negative. But multibacillary is when the lesions are more than 5, and nerve trunk thickening is there, then it is multibacillary, and if AFB can be demonstrated, that is smear positive. What are these? I'll come to it. According to WHO classification, paucibacillary treatment is for 6 months. That is, every month there is 1 rifampicin. The doses are adult dose. I'll show the picture of the pediatric also. Monthly rifampicin. So every month, early morning, empty stomach rifampicin, followed by daily Dapsone. It is for 6 months. And in multibacillary leprosy, the treatment is for 12 months, where the monthly pulse includes clofazimine also, and the daily treatment also includes clofazimine. So monthly it is rifampicin and clofazimine, and daily it is going to be Dapsone and clofazimine. And these are the blister packs, which is given free of cost by WHO to any patient who is on Hansen's disease. That is the NLEP program. According to the NLEP program, we get these drugs. On the left side, I think, to me, it's the left side. Left side of the screen is the red and the green. This is the adult blister packs. And these are the pediatric doses. This is up from 10 to 14 years. This can be followed. Less than 10 years, it has to be according to the body weight. And this is the monthly pulse, and these are the daily doses. Now, something about a few slides about reactions in leprosy. As I said earlier, it is a spectral disease leading to total confusion in the diagnosis with multiple clinical features. To add on to the confusion, we have little more features associated with the reactions. What are these reactions? These reactions are acute exacerbation of the disease, that is Hansen's disease, due to changes in the immunity of the patient in an otherwise intolerant or a silent disease. There are 2 types of reactions, type 1 reaction and type 2 reaction. Type 1 reaction, that is type 1 lepra reaction, usually occurs in the borderline spectrum, that is borderline tuberculoid, mid-borderline, or borderline lepromatous. And you can see here the existing lesions, they become erythematous, edematous. And it is something which can closely mimic an erysipelas. It can be misdiagnosed for an erysipelas because there will be pain, there will be tenderness of those lesions. And these are another few pictures of type 1 lepra reaction occurring in the existing Hansen's disease lesions. In mild reactions can be managed with analgesics, but in severe reactions, if it is associated with neuritis, oral steroids is needed to preserve the nerve and the function. And there is type 2 lepra reaction. In type 1, I said the existing lesions becomes erythematous, edematous, painful, and all those things. in type 2 lepra reaction, which occurs in the lepromatous type, that is borderline lepromatous and lepromatous leprous type. I hope you can make out. These are the erythematous nodules, which are relatively transient, which comes and goes with spikes of fever, malaise, so there is systemic symptoms also. And these lesions are new lesions, which are a bit of a transient lesion. And this is another important thing, which is usually misdiagnosed as recurrent urticaria. And we had actually had 2 patients who were misdiagnosed as urticaria, finally turned out to be type 2 lepra reaction in lepromatous leprosy. And the treatment here is corticosteroids, thalidomide, clofazimine, and analgesics. So the basic idea of my presentation here is, with multi-drug therapy, we can treat the patient. But that is what I meant was the bacillary load can be brought down to a very low level or 0 level. But to diagnose early is very important, because we don't want a person, though bacteriologically 0, but to have the stigma of Hansen's disease associated throughout his life. Diagnose early and get a person with normal limbs so that he or she can lead a normal life just like any of us. So the basic idea is to diagnose Hansen's early so that we can prevent the deformities which cannot be completely masked once they occur. Goodbye leprosy, tomorrow without leprosy is our motto. Thank you for your patient hearing.
Thank you, Joan, for that informative talk. And I enjoyed the session. Actually, we were going back to our college days, MBBS days, as well as in PG also we had dermatology sessions. So actually, one month posting was
coming
there.
To our department when I was doing,
Yes.
we were doing a super specialty.
It was very interesting, because in 1 month we will think that we will learn everything in dermatology, but in the next month we will forget everything also, because we are not seeing that daily. So dermatology was always a fascination for me, and as I have taken neurology, actually I am seeing so many neurocutaneous, so many skin manifestation. We have seen neurotic type of leprosy in adult practice so much, but in pediatrics it is much less. And it was very, very informative. And over to Dr. MKC sir has joined, and sir's opinion. Sir, you please unmute yourself, sir. Sir, you can unmute.
Okay, now it's okay. John, I'm listening to your talk. I think it's wonderful. The only other pediatrician I have heard talking about is from UP, Lucknow. The great man's son, he talked very nicely. He spent his life on that. The most important part I think you emphasize is that the drug therapy, the new drug regimen, how we can do about 10 years, the same dose, but below that, go on with the drug dosage, per kilogram dosage. That is the greatest point. I got it. And some reactions. If you can make one more comment about those reactions, how commonly have you seen? Because this is what you said is much more theoretical. What is your personal experience of reactions?
Sir, because if in the borderline type, that is borderline tuberculoid, especially the mid-borderline, if we get a case of Hansen's, even though if the patient is not on reaction, when we start the patient on treatment, we tend to get, because once the immunity of the person goes up, they start developing the reaction. And it's not that rare, sir. At least when we get those cases. And then lepromatous leprosy, type 2 lepra reaction. We still have patients on type 2 with type 2 lepra reaction. That is, I think, maybe much more common compared to those patients.
The point I was asking, is it like any other drug reaction, immediate or late?
So it is usually late.
Late, that's the point.
Usually after beginning the treatment after 6 months. But of course, a few cases present with, that is type 1 lepra reaction. But type 2, because it is due to the increase in bacteria.
Lepra reaction is not allergy. Is it allergy?
It is not allergy per se, sir. It is
That's what I'm saying.
a response to
That is
impact.
different. But
Yeah.
allergy, normally we look for when you are giving a drug, you expect immediate one. Here is a long, prolonged treatment, and you at any moment you can
get a reaction.
That's the
So
point. Thank
talking
you.
to the patient is very important. Now also we have a patient in ward, because it is very difficult when they get the reaction, they stop the treatment, because it is like madinadutha asuvam korangilla kudi. Then along with the talking to them, we tell them that is a good sign that your body is responding to the disease. So please don't stop it.
Very good. Very good point. Very good point.
Yes.
In IAP textbook of pediatrics, we have a whole section on leprosy. That's the point.
Thank you so much.
Thank you, dear.
Parvati madam, just
excellent presentation, Dr. John. And stigma is not only with the word leprosy, even with dapsone. And dermatologists usually prescribe dapsone for other conditions as well. I still remember a person who committed suicide. The chemist said, "Oh, you are taking dapsone, that is for leprosy." And this young fellow committed suicide thinking that he has leprosy.
Sure.
So even dapsone, that chemist remark made him commit suicide. Okay. Wonderful talk. Reminded of our school, college days.
And Ananda madam, a few words. Ananda madam is there?
Yes, can you hear?
Yes, madam.
Is
Nice
there any
to see you,
place
madam.
where there is... Hello, good evening.
Nice to see you.
Is there any place where there is an endemic of leprosy in Kerala?
No, madam. Because in Kerala, all the districts are much less than the elimination point also. Elimination is 1 per 10,000 population. Most of the districts are below, Kalpana madam, you were with me, right? When they showed that. It is less than 0.4 or even 0.001, all those types. Coming up to 0.11 for whole of Kerala state.
Okay, what about vaccine?
Vaccines, madam. Vaccines actually, NLEP doesn't promote vaccines. But earlier we used to give vaccine in our hospital also. I'm working in Karakonam, we used to give vaccines. But nowadays we have stopped giving vaccines, because there's one view that with vaccine, when the immunity increases, the the chance for type 1 lepra reaction increases. And type 1 lepra reaction is one which is associated with more of neuritic issues, a nerve problem. So then we all just stopped giving it.
Okay, thank you. Good presentation. Thank you.
Jovan, I heard that in that meeting that it is presenting late and diagnosis is often late. That is what people were telling there, and they have lost fingers of patients like that.
Yes, ma'am.
Just
the
tell about that
still we
also.
have in our ward is just like that. We have gone to a number of persons. Then most of the time now we are getting cases from surgery because of this amputation part and all those ray amputation. Posted for ray amputation, then someone finds a patch on the skin, and for clearance they come, anesthesia clearance they come, and then like that.
So they are actually lepromatous type.
Madam, should be most of them will be that borderline lepromatous to lepromatous. Actually, lepromatous has a better prognosis if diagnosed earlier. Earlier days, during my PG days, my sirs used to tell me that if you are given a chance, you will get Hansen. Which type will you prefer? Then it should be lepromatous, because the damage is late in lepromatous. Because the damage is due to the increase in bacteria, and the bacterial load, the multiplication is time is very high. As I said, nearly 13 days per day. So that takes a lot of time. But in the borderline and all those groups, when the immunity is high, the immune mechanism is the cause for all the damages, the nerve damage and all those things.
Yeah, Dr. Geeta was telling about this people from outside Kerala, that is the workers are coming, and that may be the reason for the increase in number.
Even we also thought like that, but state leprosy officer with her statistics, we had one paper, madam, you were there with the presentation, right? She said it is not them, you need not blame them because they contribute only a very little group of Hansen's diagnosed in.
But you may need to check it at Perumbavoor area because Karakonam area, very little of outside people.
Yes, sir. Right.
This was the state of Perumbavoor.
No, sir, this was the state statistics that they were telling. They are telling that only 51 are from outside Kerala or something like that.
400 something, only 51 is from outside Kerala. That's that was what madam's this thing was like.
And they were telling about the stigma that is still present in the community, and so people are not coming up. Even then, the workers are going there. Nobody will be cooperating with them. That is the problem.
And then another thing they highlighted was the white collar people also getting Hansen's.
Yes.
IT professionals, all those things. And then the problem is, even we had one teacher. She was least compliant to the treatment because the family believed that Hansen's is not a disease for them. It is for people with poor and poverty-stricken people. That is another burning issue.
Dr. Fettil? Dr. Fettil, a few words. Dr. Fettil, are you there?
Good evening. Good evening. Am I audible?
Yes, yes. Yes.
Yeah, it was a very clear and lucid presentation, as I said. So many of the things that we forgot about and maybe did not actually read about in detail at that point of time or later in our planning process or administrative career, those were made very clear by you, Dr. John.
Thank you so much, sir.
One little thing which is personally in mind right from when I was an MBBS student till now is, do we really need to call it a lepra reaction? Can't we call it by some other name? Because we try to remove the word leprosy and put Hansen's disease and all these things. So do we need to put this lepra reaction? Because that was one word, even during student days, it caused some amount of scare and fright among the students.
Great idea. We call it L reaction.
Yeah, that would be good, sir. Nice idea.
Good idea.
Yeah.
L reaction.
Yeah, I mean, it is, we say the fact, but nobody realizes what it is. So that's a very good word that you have suggested, sir. L reaction. Something like that. Maybe John should present it among the fora of dermatologists all over India. And get the whole country to agree that we
term, sir.
No, but still we can say, actually it is stigmatizing. It says stigmatizing, and WHO talk about stigma maximum. So we can definitely suggest. WHO is not end of everything. We can also suggest.
Sure,
you do it and we will give you more felicitations, Dr. Felicita.
No, I'm not joking. He is saying seriously,
yes,
I think it's a good thing you can do, because WHO was talking about ORS. It is the one single man in India, Delhi, who actually fought against the whole WHO concept and talked about low osmolar, ORS. Yes. And now WHO has accepted it. Dr. Mittal. So we also can be right.
WHO need not be very inflexible, not a rock or anything.
Yeah.
Okay, that is nice. And sir, can we go on to the next session?
Sure. Madam, actually, we have a question there. Actually, only one question.
Okay.
Can you answer?
Can you ask that?
Yes, madam. How to differentiate indeterminate leprosy with no sensory deficit from P. alba in children? There is a question to madam.
Yeah, actually that is a difficult thing, but the thing is, pityriasis alba will have fine scales. It is basically an eczema, dry eczema, pityriasis alba. So the dryness and the scaling will be there, and the rest, and with the lens, it will be more evident. And on top of it, now we have something called a dermoscope, which makes things more clear. Something just a bit lower than the usual histopathology, because taking a biopsy from the face of a child is not that feasible or not that good.
How does the dermoscope look like? Is it like a magnifying thing or?
Yes, ma'am. It looks like just like a magnifying lens, but it has more magnification, this thing, and polarized light and all those things. And we can take a picture with the simple mobile only. It is just handheld only, but cost
Okay.
1 lakh plus. That's it.
But for you, it will be very good,
Yeah,
isn't
it's
it?
very useful, especially for children, when it comes to children, and then malignancy, non-malignant lesion. Basically, those things.
And sometimes we are confused regarding this nevus anemicus and our Ashleaf macules for tuberous sclerosis, like sometimes, but not
The
always.
borders and all will be very well defined with the dermoscope. Borders
Yes,
of the lesion.
You can see very clearly. Like
Well
that.
taken.
Dr. Kalpana, I missed Joanne's talk because I made a mistake of, I thought it was starting at 8 o'clock. So maybe I'll listen to your talk after this thing. Two comments, Dr. Joanne. I don't know whether you have covered that area. In 90s, in Thrissur Medical College, my HOD, Dr. Paradi Madam, and myself as the. And one day, 8-year-old girl child was brought in ICU with cholestatic jaundice situation. There were lymph nodes, and we were finding it difficult to have a diagnosis. Peripheral smear showed atypical lymphocytes, and none of these viral markers were positive. IMN was negative. So at the end, it turned out to be she was taking Dapsone, and the family was not revealing that fact. So then only we came to know about Dapsone syndrome.
Dapsone syndrome.
Dapsone syndrome is one entity. I think it's a very rare situation.
So we get to see cases. Though we give a lot of Dapsone for Hansen's patient, most of the Dapsone syndrome are seen when Dapsone is given to other conditions. I don't know why. For dermatitis herpetiformis and all those things we give, the proportion of Dapsone hypersensitivity which we see is more compared in, I don't know. It's just my personal observation. I don't know.
Then stop and maybe recovered. Another thing, at that time in the 80s and 90s, we were getting many cases of Dapsone poisoning in younger children, methemoglobinemia, and we could treat it with methylene blue, and survivals and loss of lives were also reported. But nowadays it's coming down. Not many cases of Dapsone poisoning.
Maybe because of the blister pack. Earlier it was in bottles and the children used to love taking it like that. Now it is
50 milligram also was toxic. Even one tablet of 50 milligram can cause toxicity, I think.
Particularly in areas where G6PD deficiency is there. And Punjab, I have seen plenty, because G6PD is very common there. So Dapsone poisoning with hemolytic anemia, a whole lot of, even renal shutdown, we have seen so many. Okay.
At that time, methylene blue was not available, and one of our house surgeons prepared this.
Yes.
That is Paradi Madam was there.
He's in UK now.
Methylene blue is available now in India itself, so it's easy to treat. So sorry for the delaying for the next talk.
That is okay, sir. It is very, very useful. So now I call upon our dear MKC sir to introduce our Sheila. Sheila is my classmate.
Let me say, this talk was probably not a glamorous subject, but she has made it glamorous. That is my comment on this talk. Subject may not be very glamorous, but she made it glamorous. Now talk about Sheila Namboothiri.
She is Samson sir's daughter, sir.
Okay, I know. Okay.
Whose wife, sir?
Okay. And I don't know what to say about Sheila Namboothiri except that she is a workaholic, work addict, who actually, I never thought she will reach such great heights in the beginning. She was just an ordinary PG, but slowly I realized how much effort she take to learn new things, neurology, genetics, and all that. And I think Dr. Anandam will remember that probably she woke up almost every day, I think, with some complaint. Anandam will make comment on that. Wonderful girl. She has actually gone to England, got formal training, but much more than that, nobody, the so-called, very well trained genetic people have not published as much variety of cases as this girl has done. I call her a girl because I always think of her the way she was my house surgeon and PG. Wonderful presentation, and that capacity to present is so important for publish, is so important for genetics. And incidentally, she published a full book on genetics. And what I recommend that book only because it is very lucid language, very simple language. And she has done a wonderful job with that. Thank you.
Ananda madam, please say.
I think Anandam should make a comment because she has bothered Anandam more than me. Madam, are you there?
Can you hear?
Madam,
Yeah.
are you there?
Yes, yes. Oh,
Madam, a few words on Sheila.
I know Sheila from the PG days, and we must appreciate her hard work, perseverance, and then the night she'll call me and then discuss all thing about the symptoms and everything till she makes a diagnosis. And I think she's a wonderful person, and she has gone to this height because of her hard work, as MKC said, as well as her perseverance and her interest to learn new things. So that is how she found out new genetic details also of all diseases which we used to refer also to her to find. Later on, we used to refer patients to her to find out what is wrong with this patient, because she will just go ahead and do it. Please, Sheila, start talking. Thank you.
Thank you. Thank you, my respected teachers. And the madam and MKC sir, I'm really, I'm feeling emotional. Can you see the slides?
Yes, yes.
Is it in the full screen mode,
Yes,
Kalpana?
yes, full screen.
Madam.
So, a very good evening to you all, respected teachers and my dear friends. And I really thank my dear friend Kalpana for giving me this opportunity to talk on approaches to skeletal dysplasia, which is very close to my heart. Just one point, when I got trained from UK and came back to Cochin, to Amrita, actually the center where I was trained, they were not seeing that much amount of patients with skeletal dysplasia, because even when the time at 2004, 2005 itself, there were lots of subspecialties happening in genetics. So whenever there is a skeletal dysplasia, those patients were referred to other centers where the skeletal dysplasias are being seen. So once I came back to India, it was very difficult, because the first case when I saw, it was extremely difficult. Then after that, I had to see Undapakru and all. So we have done prenatal diagnosis to him. So at that time, I had gone to Germany to learn about skeletal dysplasia and Professor Andrea Supertifurga. So actually, it took more than 10 years for me to get some idea about skeletal dysplasia. So I'll start my presentation. So coming to the history, the first and most important thing is that we should ask for the history, whether there is a consanguinity or not, because there are lots of conditions which can present in families where there is a consanguinity. So for this, we'll have to do a 3-generation pedigree. So I think each and everyone should start drawing pedigree, because that is very important, so that we can draw conclusions out of that. And we should also check when a patient is presenting with a suspected skeletal dysplasia, we should check their parents as well as their siblings. Might be they are having a milder variety of that skeletal dysplasia, so it is extremely important to check that. And coming to antenatal history, we should always check whether the short stature was there from the antenatal scans itself, because some of the conditions can present in the antenatal period itself. For example, in 3M syndrome, in achondroplasia in late stages of pregnancy. So in spondyloepiphyseal dysplasia congenita, in all these conditions, the babies can have short stature presenting from antenatal scans itself. So as soon as we start seeing the patient, these are the measurements that we should take the length, the upper segment, lower segment ratio, because we want to know whether there is is it a disproportionate short stature or a proportionate short stature, and head circumference and weight. And the other things, key points in history include at what stage the short stature has become obvious. it is very important to know because for example, in achondroplasia, in hypochondroplasia, in achondroplasia, the patients will be having short stature at the time of birth. And also in patients who are having cartilage hypoplasia, they will be having features of short stature at birth. But whereas in patients who are having pseudoachondroplasia, the babies will be having perfectly normal height at birth. And usually the short stature will become manifest only after 18 months. So I have seen a family where the mother was constantly telling me that this child was having perfectly normal height. Once the child was given injection at 1.5 years, after that, this child had become manifesting short stature. So it was very important that what the mother has noticed was absolutely right. When the patient is presenting with multiple fractures, you should always ask whether whether the trauma was trivial or was it a very strong trauma, whether the child is having associated blue sclera, dentinogenesis imperfecta. So in some of the families where the parents are also having osteogenesis imperfecta, they might not be having a very severe variety. Might be they only have extensive caries. So we should always ask, because when now people are doing lots of management for the teeth issues. So what happens is some of the patients might have come with a completely what is it called, denture, or completely they would have capped teeth. So you might completely miss it. And delayed closure of anterior fontanella is very important in cases where there is cleidocranial dysostosis. And congenital heart disease and polydactyly is important in cases of Ellis-Ventrell syndrome. And whether you should also check whether there is any supination pronation defect. So in my presentation, what I have done is I have taken few scenarios so that you will understand the importance. And coming to the examination, the length, the upper segment lower segment ratio to check whether it is a proportionate or a disproportionate short stature, and whether it is a rhizomelic, mesomelic, or acromelic. That means whether there is a shortening of the upper arm or the middle or the forearm or the hands. And I will show you a few pictures now. And head circumference is important to check whether there is a macrocephaly. And limbs, you should always check whether there is talipus, bowing of the long bones, asymmetry, congenital dislocations, excess skin creases, flat face, and cleft palate. So the other examination features include limitation, whether there is a limitation of movement or contracture, brachydactyly, polydactyly, radial defect, cleft palate, and whether there is a teeth anomaly, and whether the hair is sparse, and macrocephaly in achondroplasia. So I just wanted you to understand that you just need to have a whole general examination for having a definitive diagnosis in a case of skeletal dysplasia. So these are the 5 X-rays that you should take in all suspected cases of skeletal dysplasia. One is the X-ray of the wrist with fingers, the AP view, the pelvis AP view, thoracolumbar spine lateral, and the skull lateral, and a chest AP view. So having gone through the basics, so this is the rhizomelia. Here you can see that the child is having a shortening of the upper arm, whereas the forearm and the hands are not short. So this is classically seen in a patient with achondroplasia. Here, this is a patient with acromesomelic dysplasia. Here you can see that the upper arm is having a near normal length, whereas the forearm is shortened and the hands are also very short. You can see, so this is the mesomelia, this is the acromelia. So coming to achondroplasia, this is the most common type of skeletal dysplasia that we will be seeing in our clinical practice. This is a disproportionate type of a short stature. And here the patients will be having rhizomelic shortening of the upper and the lower limb. That means the humerus as well as the femur will be very short. And they will also be having trident hand. I'll show you a picture in a minute. And they will also have macrocephaly with frontal bossing, depressed nasal bridge, midfacial hypoplasia, kyphosis of the thoracolumbar spine, and prominent gluteal region because of the secondary pelvic tilt. And the most important thing is that I have seen innumerable families saying that I have had at least 5 or 6 scans throughout the pregnancy, but it was completely missed. So please understand that it is prenatally detectable only after 24 weeks. So what happens is at 20 weeks, each and every pregnant women will be having the anomaly scan. So in the anomaly scan, it will not be there, and it will be manifesting only when the next scan is taken either at 28 weeks or at 30 weeks. So in that period only the achondroplasia manifests. So So that's the reason why it is diagnosed at a late stage. So in this picture, you should notice that this baby is having lots of skin creases. That is because the underlying bone is short and the skin is having the normal length. So that is why the babies will be presenting with lots of skin creases, especially in the upper and lower lips. And this is the typical trident hand. That means the distance between the from the middle finger, there is a gap between the fourth and fifth finger, and there's another gap between the second and third finger. So this is called as a trident finger, or this is otherwise called as looks like a trishulam. So as having 3 prongs. So this is the trident. And what are the classical X-ray features? So this is a small baby who is having achondroplasia. So here you can see that this is the squaring of the pelvis. This is the squaring of pelvis. This is the short sacrosciatic notch. And in small children with achondroplasia, you can see that the upper femoral epiphysis, upper end of the metaphyseal region, there will be a radiolucent area. You can see here that it is radiolucent here, and the fibula will be longer than the tibia. So these are, and they are for a baby, these are little stout bones. So this is the classical feature what you see in the pelvis. And in the thoracic spine, what you can see is that this is the interpedicular distance. Normal human beings, what happens is from when it goes from the lumbar to the sacral region, it will be diverging. Whereas here I have marked it. It is 1.77 centimeters, but in the lower lumbar region, in the L5 region, it is only 1.22. So it is converging. So this is the classical feature in achondroplasia. Then the other thing here is, here you can see that the upper arm is shorter. And these are called as this is the proximal phalanx, this is the middle phalanx. You can see that it is called as the bullet-shaped phalanges. This is the third finding. And this is the classical kyphosis of the thoracolumbar spine, which is seen only in the infancy. And another feature here is the bullet shape of the, in the lateral view, the vertebrae will be having a bullet shape. This is the skull, there is macrocephaly with the frontal bossy. So these are the classical X-ray features: large skulls with frontal prominence, decreased interpedicular distance from upper to lower lumbar spine, short pedicles in the lateral view, squared iliac bones, horizontal superior acetabular margin, small sacrosciatic notch, and radiolucent area in the upper femur. Please note that the radiolucent area in the upper femur is a feature which is seen only in infancy. In big adult people, it will not be seen. I just forgot to show you the horizontal superior acetabular margin and short pedicles. I will just show you. This is the short pedicles here, and this is the horizontal. This is that's the horizontal superior acetabular margin. So these are the classical features of achondroplasia. So for the students who are attending, I think you can remember two words. One is the trident pelvis. There are 2 tridents and there are 2 bullets. One is trident pelvis and trident hand, and bullet-shaped vertebra and bullet-shaped phalanges. So if you can remember this, I think it will be useful for you when you are writing a short note. And so how do we make a diagnosis? So it's a targeted mutation analysis. You don't need to do a whole exome sequencing. So it's a targeted mutation analysis of 2 common variants of the FGFR3 gene. And this is a gain of function mutation. So in autosomal dominant disorder, it can be gain of function or it can be loss of function mutation, but here it is gain of function mutation. So the importance is that throughout the whole people, around 99% of the people will be having either be changed as 1138G2A or 1138G2C. 1138G2A in that codon, it is seen in around 98% of patients, and 1138G2C is present in 1% of patients. So for diagnosis, you need not go do a whole exome sequencing, just do a targeted mutation analysis. And I have not yet seen another patient who is having any other mutation other than this. We have more than 60 patients with achondroplasia. So how do we offer genetic counseling? Because when one family has a child with achondroplasia, the most important question what the family asks is, what is the recurrence risk in future pregnancy? So the recurrence risk for the unaffected couple, because you all know that most of the families who come to us with a child with achondroplasia might be having a normal stature. So the risk of an unaffected parent is only 0.02%. But still, what I personally feel that The families who have a child with achondroplasia and those who are born to a family with the normal height, still they would say that we don't want to go through another chance of even it is 0.02, we don't want to go through because we can make a diagnosis only after 24 weeks by ultrasound scan, but by that time we can't do any other thing. So many families, they go ahead and they do an amniocentesis or chorionicular sampling to check whether the baby is affected or not. And I just want to reiterate that point that it can be picked up only after 24 weeks by ultrasound analysis. So now a new medication has come in. It is called as, the name is vosoritide. It is a C-type natriuretic peptide analog, and it has been approved by FDA for children with achondroplasia. Currently, it is approved only for children beyond 5 years of age. And phase 3 studies have shown that it can provide a growth velocity more than 1.57 beyond the normal height gain per year. So having gone through a child case with achondroplasia, now I'll take you to another scenario where this is a child with who had presented with short stature and was referred from the endocrinology department. So most of the patients with this child has a condition called hypochondroplasia. So most of these children who are presenting with hypochondroplasia, usually they go for evaluation to an endocrinologist. So here you can see that there is a increase in the length of the trunk. And this is another patient who is having a bolex or genuvarum. So in hypochondroplasia, these patients will be having short stature with long trunk. They also will be having slight macrocephaly, and and one good clue here is they will be having an associated limited elbow extension and supination. Genuvarum is seen in early childhood, and moderate narrowing of the interpedicular distance. I have already showed you that that can be there in this condition also. And they also have a disproportionately long fibula and short long bones with wide metaphases. So for you to understand, the skeletal changes are qualitatively, it is similar, but it is quantitatively much milder than achondroplasia. So the skull and pelvis are much more affected in achondroplasia, whereas it is less affected in hypochondroplasia. So if a patient has not been treated, what will happen is these patients will be having height of somewhere around 132 to 147 centimeters. Some patients are getting treatment with growth hormone. So there will be some improvement for them, but it will not be as good as for something like as if you are giving treatment for a patient with a proven growth hormone deficiency. That much amount of improvement will not be definitely there. Maximum they will be getting a height of around 8 to 10 centimeters. So here the mutation is in the FGFR3 gene, same gene. And here what happens is around 50% of the patients have a same mutation in C1620A, and a very, very small percent of patients in 1619A. So, sorry, C2A. So, here also we specifically check for only these two mutations for hypochondroplasia. So, this is the X-ray. Here also you can see that these patients will be having hefty bones. You can see that the bones are much stouter than what you expect for a child. And the fibula is longer than the tibia here. And here you can see that it's a mild squaring, not as much as the other condition what we have seen in achondroplasia. And the skull is also, there is macrocephaly with frontal bossing, and there is carpal bone age delay. Now coming to the next scenario, this was a child who was a 4.5-year-old child born to non-consanguineous couple. First child, short stature was noticed at birth. So that's very important. I have told you that in some of the conditions, the short stature can be present even during pregnancy. So the length of the baby at birth was only 41 centimeter, which is much less than what you expect. The head circumference was 34 centimeter. The child had normal motor and mental milestones. And at 4.5 years, the child was having a height of only 83 centimeter, which was less than third centile. So the other clues were that the child was having sparse, hypopigmented fine hair with brachydactyly and hyperelastic fingers. Here you can see that the child is having very, very significant sparseness of the hair, and there is hyperelasticity of the fingers. And the child has normal intelligence. So here, the degree of short stature, once you see the X-ray, I will show you the X-ray in a minute. The degree of the short stature is much more than what you see in the X-ray. And these patients also will be having short, stocky tubular bones with curved femur. And brachydactyly is they will be having very, very short hands and fingers and disproportionately long fibula. So here, only if you think about this condition, you will notice that there are typical metaphyseal changes. You see, there are typical metaphyseal changes are seen here. And this is called as the constriction of the upper femoral head. And here you can see the typical brachydactyly. And here, if you see very closely, you can see that the radius and ulna are little bit, they are looking like V-shaped. So, and this metaphyseal changes are seen in the upper tibia, lower femur, and also in the lower tibia and fibula. So this condition is called as cartilage hair hypoplasia or metaphyseal dysplasia of McCusick. So this is due to a mutation in the RMRP gene. This is an autosomal recessive disorder. The length at birth, this is a clue. The length at birth will be definitely, it will be less than 3 standard deviation. They have normal intelligence. If the adult height is usually very, very less, it is only 111 to 137 centimeters. The important point here is around 11% of patients can have an associated Hirschsprung's disease. They are very much prone for varicella infection. So once you make the diagnosis of cartilage hair hypoplasia, we will always give them a varicella vaccination in infancy itself. And they have an increased chance for immune deficiency because there are patients who have near normal hair also. So those who are having associated hair hypoplasia, they have increased chance for immune deficiency. So live vaccines are contraindicated in patients who are having associated cellular immunity defects, and there is increased chance for non-Hodgkin's lymphoma. We have 2 patients who had non-Hodgkin's lymphoma and who had cartilage hair hypoplasia. So now I will take you through a much common condition, which is osteogenesis imperfecta. Here, what I have shown you is the lethal type of osteogenesis imperfecta, where a baby was born and the baby died on same day itself. And what you can notice here is that when you see this X-ray, you might think that this X-ray was not taken very clearly, but it is not like that. It is because of the hypomineralization. You are unable to see the bones well, and there are multiple fractures of the ribs, and there is no skull ossification. And here, this is another baby, an infant, where you can see that the skull ossification is very, very, very poor, and the skull is very thin. And this is a very early pregnancy because this was a pregnancy that was terminated somewhere around 18 weeks of gestation. And whereas this is the X-ray of this same baby who was born at birth with lots of fractures. Here you can see that there are the femur is very, very thick, and this type of femur is called as the accordion femur, because the reason is that there were multiple fractures which has happened in utero, and these fractures have united inside the uterus itself. That is why it has become very broad. So if you are diagnosing the condition very early in pregnancy, the bones will not be very broad, it will be very thin. And here you can see the V shape because of the multiple fractures. Here also you can see V shape of the tibia with multiple fractures. And here also you can see there are multiple fractures which are in the different stages. Some are healed, some are active fractures, and there are multiple fractures of the ribs also. And this is the blue sclera, and this is the dentinogenesis imperfecta, what you see in a child with osteogenesis imperfecta type 1 and type 3. And this is one good clue. What you can, once you see something like in a very early pregnancy, once you see multiple fractures, and once you see that the long bones are very, very short and curved, what the ultrasonologists will do is they will do a compressing technique. So with the transducer, they will try to compress the skull. And you can see that just because the skull is completely unmineralized, you can see that the skull is getting compressed. So this is a very good clue for making the diagnosis. The only other differential diagnosis to this condition is hypophosphatasia, where also you can see this kind of where the skull is compressible. And in this ultrasound, you can see that there are very, very tiny bones. The tibia and the femur are very, very short. This is because the multiple fractures have happened in utero. This is a bigger child, where this is a type 3 child, where the lots of fractures have happened ever since the child was born. And you can see that there is lots of non-union. You can see this is a non-union. And this is called as here you can see this is called as a popcorn appearance. And you can see that there are lots of curvature of long bones, and the fibula is so thin. Here also you can see the fibula is very thin. So these are all type 3 osteogenesis imperfecta, which is a very, very deforming type of condition. And here you can see that this is a type 5. Type 5, in this condition, what you see is that in type 5, you can see the interosseous membrane calcification. So this is the interosseous membrane calcification, which is seen in the lower limb as well as in the upper limb. This is very, very typical clue. And this gene is called as IFITM5. And this is lots of vermian bones which are seen in the skull due to osteogenesis imperfecta. This is a child with a WNT1 type of osteogenesis imperfecta, where the child presents with ptosis. So this is a very good clue for that condition. And here, what has happened is due to multiple compression, this is called as a fishbone appearance of the vertebra. And here, this child has received lots of pamidronate infusion. So these horizontal lines are called as the zebra lines, which are seen in a patient where the patient is having, patient is taking regular infusions with pamidronate. So in type 3, what happens is the patients will be having frontal and temporal bossing, blue sclera, generalized osteopenia, thin ribs with discontinuous fractures, and short deformed long bones. And skull ossification is in type 3 is always better than type 1. So previously, the classification which was used for osteogenesis imperfecta is called as Thielens classification, where there was only 4 types, type 1 to type 4. And the gene which was implicated was collagen 1A1 and collagen 1A2. And all these type 1 to type 4 are autosomal dominant disorders. But nowadays, with the advent of this exome sequencing, lots of genes, autosomal recessive genes have been identified. And so these are all the causes for autosomal recessive type of osteogenesis imperfecta. And these type of osteogenesis recessive types are much more severe than even the dominant type. And this WNT1, we have somewhere around 15 patients. And here the important clue is these patients will be presenting with ptosis, either unilateral ptosis or bilateral ptosis. And this is another scenario where the child has presented with short stature. Child has normal mentation. You can see that the child is having a very, very short trunk and severe pectus excavatum with kyphoscoliosis with genu valgum. But the important clue here is that the child has, even though the child is having lots of deformities like this, child has extremely hyperelastic fingers and hyperelastic wrist joint. So this is a classical feature in Morquio disease or mucopolysaccharidosis type 4. So the X-ray, the classical X-ray will be in the lateral spine. You can see a middle beaking. So for students, you can always remember Morquio middle beaking, MM. So I think you can remember it like that. And the X-ray of the hands, you can see that this is the typical radius and ulna are facing each other. There is a severe carpal bone age delay, and the carpal bones are extremely small and irregular. And there is severe shortening of the metacarpals and phalanges, and there is the proximal tapering of the metacarpals. This is called as the dysostosis multiplex. This finding, along with the feature in the spine and also broad ribs, this combination is called as the dysostosis multiplex. This is another scenario where the couple were non-consanguineous, and the baby was also having short stature, which was noticed at birth, since birth. And there was no family history of similar complaints. And at 4.5 years, the child was having a height of only 71 centimeters, even less than what you expect at 1 year of age. And upper segment, lower segment ratio was also deranged. It was 1.2 at 4.5 years. And the height was, the weight was also very less. Child had normal intelligence, short stature, less than 3rd centile, short thorax, severe lumbar lordosis, bilateral contracture of the elbow and knee, short neck, and restriction of the lateral movement of the neck, and severe pectus carinatum. You can see the severe pectus carinatum here, and the child is very, very short for a 4.5-year-old child. And this child also had severe myopia with short neck. So in the X-ray, what you can see is that upper femoral epiphysis has not appeared at all. And there is a wide pubic symphysis. So there is a pubic ossification defect. And this is called as the classical pear-shaped vertebra on the lateral view of the spine. And there's a severe carpal ossification delay. So what this child is having is a spondyloepiphyseal dysplasia congenita. So this is a collagen 2 defect. and this is a disproportionate. This will lead to disproportionate short stature. Some patients are misdiagnosed as patients with Morquio's disease. They also have short spine, short neck, barrel-shaped chest, pectus carinatum. But these patients, they don't have the hyperelasticity of the wrist or the fingers. So that's a very good clue to differentiate from Morquio. And they have normal hands and feet, flat face, and they around 50% of the patients have myopia. And age of manifestation is at birth. That is another clue. In Morquio, they will be having a normal stature at birth, and the features of short stature will manifest somewhere after 2 years. Whereas in spontaneous epiphyseal dysplasia, they will manifest since birth. And I have told you all the features, which are absent ossification of the pubis and knee, and retarded ossification of the femoral head, dorsal wedging, the pear-shaped vertebra, short spine, kyphoscoliosis, and normal bones of the hands and feet. And this is an autosomal dominant disorder. The defect is in the collagen 2A1 gene. Prenatal diagnosis is possible. And these patients are prone for cervical spine instability. I forgot to tell that in Morquio, even though there is a new enzyme replacement therapy that has come in Western countries, it is called as Vimsim, but still it has not come into Indian market. So what we can do is these patients with Morquio disease, they are having increased chance for instability of the cervical spine. So for all these patients, we will do a cervical spine CT evaluation to check whether there is a C1, C2 subluxation or not, and they will be sent to the neurosurgeon. And if there is a instability, that will be surgically correct. So that's one prevention what we can do, so that otherwise if they have a trivial fall, they can have quadriparesis. So I think this is the last case where the child has presented with short forearm. Otherwise normal child. This child was having a near normal height and everything. Then the parents noticed that the child was having they noticed that the child was having short stature only after around second standard, third standard, third standard. Here you can see that there is a definite shortening of the forearm. Once you are seeing the X-ray, you can see that there is a dorsal subluxation of the ulna. And here, if you see the hand X-ray very clearly, you can see that the radius and ulna are facing each other. Then the distal radial epiphysis is having a triangular shape. And usually in hand, the carpal bones will be in one line. Here you can see that it is looking like a V, inverted V. And this is the hamate, which is in the which is forming the middle of the triangle. So this condition is called as a Leriville dyschondrosteosis. And here there will be a dorsal subluxation of the ulna, and there will be severe radial shortening, or this combination is called as the Madelung deformity. And there will be a mesomelic shortening. That means the forearm is shortened, and they have an athletic habitus. And the X-ray features I have told you, the ulnar, and there is an ulnar and palmar slant of the radial articular surface. That's a triangular distal radial epiphysis, and the carpal bones have a triangular configuration with, sorry, I forgot to tell, it is a lunate, is the bone which is seen in the apex. And Madelung deformity is that happens due to the consequences of the deficiency of the SHOX deficiency. As you all know, the SHOX deficiency is one of the major cause for short stature in children. So when there is a SHOX gene is situated in the terminal region of the X chromosome. So you might be having a doubt why this finding is not there in patients who are having Turner syndrome. So the reason is that estrogen is the one which increases the development of Madelung deformity, and puberty will worsen it. So in Turner syndrome, what happens is there is deficiency of estrogen, and that is said to be the reason why the prevalence of Madelung deformity, in spite of loss of SHOX deficiency, why these patients are not manifesting Madelung deformity. So this is located in XP22.3, that is the terminal region of the X chromosome, P-arm, and the expression is more severe in female. And some patients can, so the difficulty in diagnosis is that some patients with SHOX deficiency, they present with only with short stature, and some other patients will present with Madelung deformity. And SHOX deficiency, it contributes to somewhere around 1% of the patients with idiopathic short stature. So these patients can be given treatment with growth hormone. So it is important to make the diagnosis of this condition. So this is an extremely rare situation where both the mother and father were having Leriville dyschondrosteosis, and they had a child with homozygous deletion of the SHOX. So it's an extremely rare condition. In past 20 years, I have seen only one patient This is called as a Langer mesomelic dysplasia, where they have significant shortening of the forearm bones. You can see that the distal ulna is completely absent, and also the proximal fibula is also completely, it is deficient. And there is a shortening of all bones, but the maximum shortening is in the mesomelic, that is in the middle segment. And they will also be having severe severe shortening of the chin, and with normal stature and with severe short stature. So this is the parents. So this is called as a typical dinner fork deformity. So this is the mother and father of this child, and this is the dorsal subluxation of the ulna, and the parents were heterozygous carriers for this SHOX gene defect. So I'm going to end this. Before that, I will show you 3 case scenarios. So this is a newborn, this is a baby who was terminated because the baby had a lethal type of skeletal dysplasia. So, so I think what you should understand here is that this is not a case of achondroplasia, but what this child is having is a thanatophoric dysplasia. Here also, this is a lethal type. Achondroplasia is a non-lethal skeletal dysplasia, whereas thanatophoric dysplasia is a lethal skeletal dysplasia. So this type of dysplasia, this will manifest before 18 weeks of gestation. So if you identify that the baby is having short stature, and if the baby is having very short femur, very short humerus, and this is called as a platyspondyly. There is severe flattening of the vertebra. This is called as a French telephone receiver appearance of the femur, and the humerus and the femur, and severe platyspondyly with normal skull ossification. You can see that there is shortening of all the segments, the upper arm, middle arm, and acromelia. So this is a lethal type of skeletal dysplasia, and this is called as the thanatophoric dysplasia. And this is the second case where a family had brought this picture of the baby as well as this X-ray, thinking that so it was referred as a case of probable osteogenesis imperfecta. But what you can see here is that here this is called as a splintering. What you are seeing here is a splintering, and the distal ulna is completely missing, and there is only 3 metacarpals. The rest of the metacarpals are missing, and almost all the carpals are, almost all the phalanges are also missing, and there is multiple fractures of the ribs, and there are the bones are it is extremely demineralized. And this is in this condition, this is a hypophosphatasia. This is also a rare condition. There is severe hypomineralization and osteochondral spurs. I have shown you. This is called as the osteochondral spur. This is the osteochondral spur, and the skull will be very thin. So here also, once you compress with the transducer, the skull will it will mold. And once the baby is born, what you can check is the alkaline phosphatase will be completely absent, and the long bones are very thin, and there can be multiple fractures of the ribs, similar to lethal type of osteogenesis imperfecta, and they will be having the less number of carpals and no phalanges. And this is the third scenario, where this baby was also, this pregnancy was terminated, but the family had this X-ray with them. And here you can see that there is a deformity in the upper, in the femur. You can see that the upper 1/3 and lower 2/3 junction, there is a curvature, and there was in the tibia, upper 2/3 and lower, they're just opposite. Here in the femur, it is upper 1/3 and lower 2/3. In the tibia, it is upper 2/3 and lower 1/3. There is a curvature. But the clue here is that there's severe hypoplasia of the scapula, and it is completely absent here. So here, what the child is got as a campomelic dysplasia. So what I would suggest would be, whenever you see a baby with a suspected skeletal dysplasia, if it's a prenatal case with a suspected skeletal dysplasia, documentation of the clinical features of the fetus is very important. Once the baby is delivered, it should be shown to the pediatrician so that all the features can be noted. Rather than writing as multiple congenital anomaly, we should mention what exactly the baby had, whether the baby had polydactyly, whether the baby had cleft lip. All these information should be very useful. And you should take only 2 X-rays. One is an infantogram, that means the whole body X-ray, and the second one is the spine lateral view. And nowadays, each and every parent has much better mobile phones than us. And let us we should take an X-ray of we should take a photograph of the baby, and we can hand over the photograph to the family. And ideally, we should store the DNA. How we store is you can store 3 ml of the EDTA and it can be sent to any of the labs and they will store the DNA forever. And these are the tubes that we use for storing. And for karyotyping and fish, you use the green vacutainer, whereas for storing the DNA, you should use the purple vacutainer, and the red vacutainer is used for the torch parameters and everything. And now everybody has this access to filter paper. So if you can also take drops of blood in the filter paper, dry it just like that in the room for 24 hours, and it can be stored for at least for a few months, 5 to 6 months. And if by some reason, if you didn't have the facility to take the blood of the fetus, you can take an umbilical cord around 5 centimeters of the umbilical cord and you can send it to any of the labs, including Amrita or anywhere where the DNA isolation can be done, and medical college also it can be done. So to sum up, meticulous history, clinical evaluation, and search for associated anomalies clinches the diagnosis in many of the cases of skeletal dysplasia. Identification of the type of skeletal dysplasia is very important for prognostication, and confirmation of the diagnosis of the index case is absolutely essential for parental counseling for prenatal diagnosis. I thank you all for the patient listening, and if there are any questions, I can take up questions. Thank you.
Thank you, Sheila, for that very nice presentation, very informative, and everything with our actual cases. I enjoyed the presentation so much. And Dr. Mini has something to say. Dr. Mini, please. Dr. Mini?
I was just asking whether in osteogenesis imperfecta, any particular type, there is a ear-ossical fracture leading to hearing impairment. And also regarding achondroplasia and hydrocephalus, is there any head circumference chart separate for achondroplasia patients?
Both are very important questions, Mini.
Really nice. Very, very good points I learned today also. As I learn a lot from you when you are presenting. Thank you.
Thank you, Mini.
Mini was actually sick and she just for listening to you, she came.
Thank you, Mini. Thank you. So the first question is that's very important question. Huh?
I listened the whole leprosy also. I did not leave. In between, I got out, but then I came back.
Okay. So, Mini, coming to hearing defect, somewhere around 30 to 40% of patients with osteogenesis imperfecta type 1 and type 4, they can have associated hearing defect. So, once in every year, we should definitely check their hearing, because even if they are not having hearing loss at an early stage, they can have it at a later stage. That's important. And second thing is, I just forgot to tell you, it's very important in achondroplasia. We should constantly, because we don't have access to vosoritide, the only thing what we are offering is we will check their head circumference, and once the head circumference is shooting beyond a particular level, we initially in the newborn period we will do an ultrasound evaluation to check whether there is evolving hydrocephalus or not. And if the baby is having hypotonia, and if the baby is having delayed development and delayed milestones, somewhere around the age of 1 year, we should always do a CT scan to see whether the baby is having hydrocephalus or not. And many families, they would need a shunt also for that.
That was good. Actually, this achondroplasia, I have come across cases who come with isolated gross motor delay, and when we see the AF will be very, very wide also. But it is not tense like hydrocephalus, but very wide, large head and an isolated gross motor delay. And later on only we will see the short stature actually. We will be seeing the other side. And one thing I can say to the pediatricians is always take the length as well as the head circumference. These two are always missing in all the records. So that is very, very important. And this osteogenesis imperfecta is also, my classmate's son is having osteogenesis imperfecta, that may be the type 3, and he's an engineer with Microsoft now, and he's playing guitar, everything, but very, very deformed, in wheelchair, but they are working in Bangalore, who is very friendly to the disabled person, so that they can walk and they can enter into the car, every facility is there, and so he's working very nicely.
So ever since, because pamidronate is now available, the chance of them to have recurrent fractures have definitely it has come down. So for small children with multiple fractures, we are treating them with pamidronate, which is given as an infusion once in every 3 months. And they also undergo surgical correction with the intramedullary screw. And many patients are going to school. So there, as you have told, many are having a near normal life, and those who are on and I would agree that Kerala is not that disabled friendly, but still, yeah.
Yes, they have a group called Amrita Varshini, something like that. And we often come across this patient and also endocrinologist. Dr. Shija is there. Dr. Riyas is left, I think. Dr. Shija, are you there?
Yes, ma'am. Yes, ma'am.
Just a few words.
Just now, great talk, ma'am, as usual. Just now, I posted a query. When a child with a proportionate short stature come, we do the workup for the growth hormone deficiency and other endocrine problems. But when we find that the child is disproportionate, we think of skeletal dysplasia first. So whether the child is proportionate or disproportionate, that we base that assessment based on the upper segment lower segment ratio. So how exactly to measure that ratio? Because usually what we used to do was measure the lower segment in the standing position and then calculate. Or is it better to measure the upper segment in a sitting position? What do you practice usually?
I practice the same one what you are saying, the measure the lower segment and deduct it from the total height. But what is important is we should make sure that we ourselves, what happens is when the patient is coming to our room, either the person who has let the patient in or the secretary would have taken the height. So make sure that you yourself has taken the height as well as the lower segment. So because even 2 or 3 centimeters can make a different big change. Some people they practice sitting height, but personally I am very comfortable with the other one. So I always use the upper segment lower segment ratio, which I have learned from SAT.
And also this increased lumbar lordosis as well as this vertebral problems, all this, the measurement becomes, upper segment measurement becomes difficult actually.
I know.
One more query, ma'am. Was it right for this achondroplasia? Have you started giving it? Is there any scheme by which I understand that this is not included under the rare disease?
No, Shija. It has not come into Indian market, and it is not BCGA approved. So we feel really bad. Actually, around a week back, I had seen a couple who had undergone IVF, and they are having twins with achondroplasia.
Sure.
terrible thing. It was so sad, and they were asking me whether if they are shifting to a different country, whether they will get treatment like that. Because I think now people are working in IT field, they can get shifted to a different country. So actually, that family is planning to shift to Australia.
Just the other day, a person from I believe Chris Pharma came to see me with saying that this is now approved and it is available. The cost is exorbitant. It will come to around 1.15 lakh per month or so.
Shrija, even a Chris person had come to meet us also, but I think the cost is I don't think anybody in India can afford that medication.
Yes, true.
So I have never tried to give it to anyone.
Yeah.
And also the point that Morque's disease, you have to fix the spine. That most of the time it is actually when we are seeing, we will be seeing the patient is quadriplegic. So that is what is happening. So that has not come down to the grassroots.
So we are doing it prophylactically for each and every patient who has been diagnosed with Morque's syndrome. We will do there once their diagnosis is confirmed. We'll do a CT of the cervical spine and we'll fix it. There are many patients for whom we have fixed it.
And also, I remember about the osteopetrosis also. You were looking up for the treatment for osteopetrosis long back before you had joined the genetics.
I know.
Okay. Dr. Purushothaman, sir?
I was enjoying as usual. Dr. Sheila, you were looking after, and Dr. Shankar asking only surviving babies with malformations. For one survivor, there are many abortus, many babies dying, and they are not coming to anywhere, no anybody's notice. And there is a neonatal program in Kerala, that is Jadaga Seva, visible birth defect reporting. So the person who first see this thing should be taking a picture, and in that program it will be uploaded. So that is being analyzed. I think there is a role for experts like you, Dr. Shankar and all, to be there in that program. Because you can contribute. You people with expertise in those areas can do more.
എന്താണ് സാർ അതിന്റെ പേര് പറഞ്ഞേ?
Visible birth defect.
ജാതക സേവ.
Jadaga Seva is the mobile phone app is there. Government program, just like Chalabham, this one of the thing is visible birth defect reporting. So that is to be logged in, and it's a government program, and you can upload the figures and the details, and that will be analyzed at the central level. I don't know who are the maybe Shankar or somebody from the government setup, and maybe from the private public participation. Anybody having expertise can also contribute and be involved in that. And another thing is, there should be the encouragement of collecting blood spots in the filter paper, because they are all the babies are going under the earth, and nobody can get a genetic sample. So
I just wanted to highlight one point here. So once a baby is having a lethal type of skeletal dysplasia, what happens is, as soon as the baby is diagnosed with a condition like that, the family is very upset, and they want to terminate the pregnancy. So this point I have been telling to each and every conferences for the gynecologist also. So please taking 2 X-rays is not at all difficult. 1 X-ray of the whole body as well as a lateral view. That's why I had shown you 3 scenarios where the diagnosis was considered as different one, and the diagnosis was completely different once we see the X-ray. So take an X-ray of the whole body, that is an infantogram and the spine lateral view. Give those X-rays to the family. So let them keep that sample with that X-ray with them, and also give them an opportunity either to take a photograph by themselves, or you give the photograph to them, and also take a DNA sample. Either you can take the blood of the baby, or the umbilical cord, or the filter paper, any of these things. Because even if you are not going to make a diagnosis at that point of time, you can have a diagnosis at a later stage if you have any of these things with them.
Pediatricians and OBG people, IAP and OBG Federation should be insisting on the 3 points. First one, of course, any dead or alive baby with malformation, take the X-ray and keep in their own mobile phone. Second one is, take the blood spot in a filter paper for later use. Dried blood spot can be used later. And third point is, encourage the postmortem examination, fetal autopsy, and the malformed baby's autopsy among the pediatricians and maybe the OBG people also.
Yes, OBG people, that has to be sensitized, because they immediately just leave it. So OBG is very, very important. Many a times these babies are not shown to pediatricians.
Exactly.
Because it will be...
They should be sensitized to keep the placenta, umbilical cord, and the dead baby.
Okay.
And it should be shown to the pediatrician, so that the pediatrician can see what are the anomalies, and it can be noted. Because in most of these conditions, what happens is, it will be just mentioned as multiple congenital anomaly, and there will not be any. So many families, they come to us without any X-rays, without any photographs, without any sample. So nowadays, families are coming with where the DNA is stored somewhere, so that we can have a diagnosis.
Now I call Dr. Pratap, your close friend. Dr. Pratap, please. Pratap, are you there? Pratap? He's there actually.
Yes, ma'am, very much here.
Okay.
During this IPL and Ranji season, I was reminded of all the fast bowlers of West Indies and Australia, because most of the things were bouncers for me. And so I'm not a person, or I'm not in the right person to ask any
Please,
questions other than
the
appreciate
video,
the entire
please.
topic and a
Please,
lot of
your
key
video.
points like.
I want to see your face.
Okay. Yes. Okay, you want to see my sad face? Yes.
Yes, yes.
Okay. This bewildered look, thanks to Dr. Sheila for that.
Right?
Yeah. So it was a wonderful presentation, I should say. And for me, or for an ordinary pediatrician or a clinician, the most important thing is, like, even for an aborted case or even for a neonatal death, to taking those samples and those X-rays and photographs. That's a key to this entire. At least for me, that's a key because that can give what should I say, a counseling for the parents, and even to have the prognostic for the next one. I think that's a take-home message, at least for someone like me. Thank you. Excellent presentation, as always. Thank you.
One minute, Kalpana.
Yes,
Can
madam, I was trying to call you, ma'am. Okay, just tell.
No, in the 1970s, I had a study on congenital anomalies in newborn along under the leadership of Dr. K.K. Varma, Karthikeya Varma sir, in
Surgeon.
Calicut. So that time we tried to do postmortem in few cases, but somehow or other it was very difficult to convince the parents. But nowadays the parents are willing to come up for all those things, because especially if they want another baby, you can just tell them that this is needed. So they will be always coming for that. Excellent presentation as usual, Sheila.
Thank you, ma'am. Thank you.
I always come to hear you. Okay. Then this, I think Dr. Shankar is there in the panel for the
I haven't seen
that program. That program,
Alla,
the
Jadaga.
Jadaga Seva. Jadaga Seva.
Why Jadaga has come? I don't know.
Two things I expected from you. Explain the metaphyseal dysplasia, which is coming as a commonest DD for this rickets situation we encounter. Second one is a very benign situation of a Blount's disease, middle epiphyseal.
Blount's disease.
Because these are all common entities benign among the general pediatricians. And in the hypophosphatemic rickets of the affected babies, the ladies and the mothers affected will be having a bend and short lower limbs only, upper part spare. These are all interesting things. I remember these things. I'm very indebted to Trivandrum people. Ashok Kumar sir was working in Trichur, and that time Engelmann disease is one. The deformity of the
Ashok sir is here actually. Ashok sir.
Sir was the first one diagnosing the Engelmann disease. And once I was there in Trivandrum, Noel sir was pointing out the mother with hypophosphatemic rickets showing the deformity. And Blount's disease, many cases of Blount's disease. Thank you, Sheila.
Ashok sir?
Yeah. I'm here. Sheila is wonderful. I'm a fan of Sheila. Vanitha Ratnam എന്നൊക്കെ പറയുന്ന പോലെയാണ്. Unbelievable talent. And she has no inhibition to send to communicate with Europeans and send specimens to Europeans and ask for medicines from Europe and all those things. Even men are hesitant to do like that. Sheila is wonderful.
Sheila, how many enzyme replacement you are doing now?
22 patients.
Okay. Mainly on?
Mainly on 6 patients on 7 patients on Pompe disease, 6 patients with the Fabry disease, and 4 patients with Gaucher, and then the rest with mucopolysaccharidosis, MPS type 2, and 2 with Niemann-Pick type B.
What about the finances, Sheila?
Madam, ellam free. Through free ആയിട്ട് madam, through charitable access program.
She takes personal interest and goes to the company, everything, and she manages like that. For the
Sheila,
last.
any
Wonderful.
association with alopecia and osteogenesis imperfecta?
Alopecia and osteogenesis imperfecta. So the association is with alopecia is with two conditions. One is cartilage hair hypoplasia, which I had shown, metaphyseal dysplasia. That is actually Purushothaman sir. I have already shown one metaphyseal dysplasia. This cartilage hair hypoplasia is a metaphyseal dysplasia. In those patients, they can have they around 50% of patients can have associated severe alopecia. And another condition is vitamin D resistant rickets, where the patients can have severe alopecia. Completely bald. Sorry, vitamin D dependent rickets. Vitamin D dependent rickets, they will be having total alopecia. And these are the two conditions. But osteogenesis imperfecta, I have not seen, sir.
In Trivandrum, I was the first one to give for osteogenesis imperfecta bisphosphonate. Palmitronate. So that child he's 25 years old now, and he will come to me only. He won't go to adult medicine.
Even
if
now
he has got
he's
a problem,
admitted in a
he will come to me
pediatrics.
only. അറിയാവോ ലിജു മോഹൻ എന്നൊക്കെ പറഞ്ഞ
Digimon, we know. We all know.
അഡൽട്ട് മെഡിസിൻ്റെ അടുത്ത്
Even
ട്രീറ്റ്മെന്റ്
now
പോകാൻ
he's
പറഞ്ഞ
asking
പോകത്തില്ല,
for you.
എൻ്റെ അടുത്തേ വരത്തുള്ളൂ.
So after 18 years, we send them to adult people, and they will start giving. Actually, we send them to our endocrinology department, and they will start giving them solindronate.
About this cartilage hair hypoplasia, we had a few cases in Thrissur, and that was not for the skeletal dysplasia part. It was for the immunodeficiency recurrent, short stature and the hair problem. And there, as you said, the controversy is whether to give varicella vaccine, because that's a live attenuated vaccine. It's a double-edged weapon. But you can give it because there is not much of problems. Better to give rather than avoid. There is a high chance of varicella, and varicella vaccine is a live attenuated vaccine. But the problem will not be there, because the problem happens when the count is too low. Usually they tolerate these vaccines.
Not all patients with cartilage hair hypoplasia have this immune deficiency. So if we are diagnosing in the very early infancy, we will give them vaccine at that point itself.
Around the side of the vaccination.
And over to Dr. Srijit for the vote of thanks.
Okay, thank you, madam. So we have yet another day of eventful day and fruitful day of Tuesday series, and thank Sheila madam for a wonderful talk and sharing all the private pictures and all the years of experience with us. Thank you, madam, from the bottom of my heart. And also thank the earlier speaker, Dr. John madam, for the talk on leprosy, and the seniors Purushothaman sir, Parvati madam, Ashok sir, and all. So thank you for joining us. Hope to see you in the next time. Okay, good night, madam. Good night.
Thank you.
Thank you, Sheila. Thank you, sir.
Thank you.
Thank you, Parvati
Thank you.
madam.
Thank you, madam. Sir. Thank you.
Okay, bye.